We are live.
So, hello, good evening, friends. Here is the another episode of Walk-in Patient with Allergic Eye Diseases, which is a day-to-day problem. And we have stalwarts like Biren Sangwan and other panelists who are actually will deal with the situation of how to diagnose, how to manage, and how to prevent also. So there are several aspects, and every month we have used to have two such meeting, and this is with for the comprehensive ophthalmologist, and this is for comprehensive ophthalmologist. So with that note, I will hand over. Who will conduct the session?
Yes, I'm going to conduct that.
Yeah, Bikash.
Yeah, good evening, everyone, and thank you, Dr. Basak. So we are going to do this webinar today, walk-in patient with allergic eye diseases. Close to 4-5 months back, Dr. Honavar called me and said that he wants a webinar on allergy, and this needs to be very practical, case-based. So what we did was we made a survey amongst general ophthalmologists and asked for questions. So what is it that they need to deal with when they see a patient with allergy? And we found close to 50 plus questions. And these questions were categorized into six different segments. And we decided that we are going to request renowned speakers across, and then give them this topic, and they will cover those questions in their talk. So with me, my co-moderators are Dr. Debapriya Chatterjee from Kolkata. Dr. Honavar will join in a while, and Dr. Manoj Mathur from Swaroop Eye Center. The speakers that I was talking about. So what we did was these were categorized into spectrum of eye diseases. First topic, which will be taken care of by Dr. Radhika Natarajan from Shankar Netralaya. And then we will see what are the kind of signs that you see in this VKC or allergy. How do you, if you zoom in, what is seen inside? Dr. Abha Gaur from Stoff Charity Eye Hospital will deal with it. She has an amazing work on VKC and all these allergies. Then we will see what are the medications available, how do you give those medication, what are the precautions, and how do you follow up. Sahil, an eminent and very good clinician, cornea specialist from Ludhiana, will deal with that. After that, we'll see what are the non-medical treatments available, mild surgical or anything else. Dr. Sharon D'Souza from Narayan Netralaya will take on that particular aspect. Dr. Himanshu Matalia will tell us how counseling is very important, and when this comes to allergy, what patient thinks, what doctors thinks, he'll deal with that. And we'll spend 10-15 minutes on the severe cases, that if a severe cases, a general ophthalmologist may need a cornea specialist assistance, and what exactly a cornea surgeon does in the back end. So these speakers are very eminent cornea specialists across and have more than decades of experience in dealing with these kind of patients. We are really privileged to have our chairpersons, Dr. Samar Basak from Disha Eye Hospital, President AIOS, Dr. Virendra Sangwan from Chef Charity Eye Hospital, Dr. Namta Sharma. They don't need any introduction, and we have seen we all are students of all these teachers. We have expert panel for Dr. Amit Gupta from the Advanced Eye Care Center, Chandigarh, Swati Tomar from Swanetra Eye Hospital, Jaipur, and Dr. Revati Rajaraman from Arvind Eye Hospital, Coimbatore. So I'm sure that with such stalwarts and lots of experience in hand, at the end of this webinar, you'll be able to diagnose your patients. You'll be able to take care of your allergy patient at least 95, 97%. So with this, I invite our first speaker, Dr. Radhika Natarajan. She'll be talking on what are the various spectrums of these allergies and what is a general presentation. Dr. Radhika Natarajan, over to you, please.
Thank you. Thanks to Dr. Vikas, Dr. Basak, and AIOS for having me over here, because this webinar has given me an opportunity to look back at the archives of my own allergy patients from one end of the spectrum to the other, and I hope to share some of that with you. I'll share my screen in a bit. Can you see my screen there?
Yes, Dr. Radhika, is visible. So I'll just make a small announcement. Those of you who are seeing this webinar and you have some questions, please feel free to ask in the chat box or Q&A session, and we are going to deal with it at the end. Please start, Dr. Radhika.
So I'm Radhika from Shankar Netralia. And we know that ocular surface diseases constitute a set of chronic bilateral inflammatory conditions. And as the name suggests, the disease involves the ocular surface. It is limited to the tarsal and bulbar conjunctiva most of the times. And usually it is a self-limiting disease, but rarely can cause severe problems in case of complications. Spring catarrh commonly happens in children bilaterally, boys especially in hot climates. And quite often these diseases are associated with other forms of body allergies. Some of them may be simple ones like allergic rhinitis, some may be more complex like asthma or eczema. That little pathology diagram over there shows that what is happening is the antigen stimulates the mast cell, which then proceeds to degranulate, releasing histamine and a whole of other chemokines, which then set up an inflammatory cascade. So there are various allergic entities, but they may have a lot of overlap. First is the seasonal allergy, which happens during spring or summer season. It is caused by type 1 hypersensitivity. Then you have vernal catarrh or vernal keratoconjunctivitis, which can be caused by type 1 and type 4 hypersensitivities. Type 1 is mediated by IgE and type 4 is mediated by T cells. We need to know this to institute the treatment. Then you have atopic keratoconjunctivitis, and then you have giant papillary conjunctivitis, which is caused by mechanical irritation in the backdrop of allergy. So why do we need to know these entities? Because if you see this treatment graph in the part below, you see that seasonal allergy is a very mild disease. Then when it happens very frequently, it becomes perennial. VKC is a more serious disease. And then atopy is the worst of them all. So the treatment also has to be escalated according to this scale. So we know that vernal keratoconjunctivitis is the flag bearer in the spectrum of allergy. Here you see the palpebral form, where in the left side you have mild papillae and the right side you have giant cobblestone papillae. When you see it like this, you understand the grade very well. But then you see these pictures on top, both sets of papillae look the same. But then when you stain with fluorescein, you can see that the first patient is staining intensely on the tarsal plate and therefore definitely has got more allergy compared to the second patient. Here is the bulbar form of the disease where you can see the papillae around the limbus and also follicles. There you have the blown up picture of the follicle, which is bursting with inflammatory cells and fibrous tissue. So what are these papillae and follicles? Follicles basically have aggregation of inflammatory cells surrounded by blood vessels, whereas papillae have a core of blood vessel surrounded by inflammatory infiltrate. But then when you see that the disease progresses, as you see to the right-hand side, papillae and follicles become virtually indistinguishable from each other. So it's not just important to know mild and severe disease as we saw, it is also important to know the spectrum of the disease activity in terms of whether it's active or quiet. The left-hand side, you can see Horner-Trantas dots, which are aggregates of eosinophils around the limbus, which show you that the disease is very active. But the right side picture, you can see the scar in the perilimbal region superiorly. The inset picture shows you when the disease was active. You can see a lot of staining on the tarsal plate as well as on the cornea. The constant rubbing has produced this Cupid's bow or scarring in the form of pseudogerontoxin, which tells you that the disease is quietened or at least in remission. So moving on to the next entity, which is atopic keratoconjunctivitis. It's a more serious disease. Sometimes this can run in families. The body involvement is more severe. You can have pigmentation, papule formation, pustules in the forearm and the popliteal fossa, and the same can be seen on the lid skin also. So similarly, the eye condition is also more severe. You can see the progression of AKC over here, where there are limbal nodules, HT dots, severe scarring as seen by the fluorescein staining both on the tarsal plate as well as on the cornea. Then you can see in the last picture, the blinding scarring which is happening on the cornea. This is giant papillary conjunctivitis, where you see much larger papillae, flat ones. Compare it with the VKC papillae, which are more rounded. Here, these papillae are more mushroom-shaped, and the intervening spaces are larger, separated by wider septal spaces. GPC is not even a true allergy. It is caused by mechanical irritation due to inert objects like a contact lens or a foreign body. And as you can see in the picture, here there is a suture which is jutting out. And the fluorescein picture shows you it has set epitheliopathy around it. And the picture below, sure enough, shows you that there is formation of GPC. So those were the characteristics of GPC, AKC, and VKC in the true sense. But let us see some outliers now. So in children very small who are babies, usually you don't get a typical VKC. That is because A, their immunity has not sensitized the antigens as yet. And B, in very small babies, the tarsal plate lacks the characteristic septate, they can't throw up papillae. So can VKC happen in adult? Yes, it can happen in two forms. In later stage, when it comes on, sometimes there's a trigger, like a change of place or gardening or a new house or something like that. But in these cases, you have diffuse limbal follicles and diffuse papillae. They're not very prominent. You see the gelatinous appearance around the limbus over there in the small picture. And because these are not very elevated even on the lid, they lead to lesser corneal complications. Whereas you see the picture on the right, this is a VKC in an adult, but this adult has HIV. When you have florid VKC like this in an adult, you have to rule out HIV. And in this patient, you can also see the mucus as well as the keratin pearls over there. Underneath that is also lurking an OSSM. The chronic limbal stimulation because of the VKC in the backdrop of HIV has set up this OSSM. What happens in HIV is there is an imbalance between the T helper 1 and the T helper 2 cells. Th1 promotes immunity and that is lacking. So these people are immunosuppressed and therefore Th2 predominates, which leads to allergy. And no use of steroids in any amount will quieten this disease. You need to institute antiretroviral therapy, normalize the CD4 count, and then the Th1 and Th2, when they equate, you can expect some amount of remission of this allergy. So it's not as though the disease should become complex only when it is very active. It can throw up complexities when it is resolving as well. So the picture on top shows you the normal limbus, but see the flow of pictures below. VKC has taken hold of the limbus. And as it progresses, in the last picture, you can see that the papillae and the follicles have scarred completely, destroying the limbus actually when the disease is burning out. Also, we know that VKC can be associated with keratoconus many times because eye rubbing is a factor. But when we do cross-linking in these patients, even if the disease is quiet, sometimes it leads to severe scarring. You see keratoconus with VKC in the picture on the left, and post CXL, you can see the scarring in the slit picture. And the ASOCT, where the arrow is pointing, shows even disruptions in the Bowman's membrane. So VKC is not always, allergy is not always characterized by papillae and follicles. It can present in other ways too. Take a look at this patient. There is discoloration of the lid skin, and also you can see muddiness of the conjunctiva. So this is postulated to be because the constant eye rubbing stimulates the melanocytes, and then you can get pigmentary dispersion on the ocular surface, which can be a very important sign of the allergy. This patient has limbal nodules, but in the right-hand side picture, you can see that she has some unusual conjunctival ulceration also. We know that allergy patients rub their eyes, so there is constant epithelial irritation, and some of that epithelial, gets into the subconjunctival space, and it can produce an inclusion cyst. The left top picture shows you one cyst. There, in the left bottom, you can see a large transilluminating inclusion cyst. The same irritation can also cause symblepharon formation, which you can see in the right-hand side picture. And in the same patient over here, you can see tarsal scarring. The central pictures show you upper lid and lower lid severe tarsal scarring, and the pictures on the right and left show you severe bulbar scarring as well. At a first look, this may look like cicatricial eye disease, but then you delve a little deeper. These patients are symptomatic from childhood. There was a history of eye rubbing and allergy, and you know your diagnosis. Why should you know this? Because if this is VKC, this is probably representing the resolving or the burnt out stage of the disease. But if it is ocular cicatricial disease in its autoimmune form, then the disease is probably very active even now. Sometimes allergy and infection can be playmates. So here was a patient of VKC in the resolved stage. You can see the pseudogerontoxin and you can see the corneal scarring was referred to us for lamella keratoplasty. But then you put fluorescein stain, you can see bits of dendrites over there. Frequent use of steroids invites HSV to reactivate in VKC patients. So this left-hand side picture shows you VKC with corneal involvement, where you can see in the slit picture only the anterior cornea is scarred. Whereas when there is HIV, as you can see in the right-hand side pictures, especially if there is stromal involvement, even the deeper layers are affected, and the ASOCT actually shows you even endothelial involvement. You need to know about this because unless you know the layers of involvement, you cannot plan a lamellar keratoplasty, which has to be then done with control of VKC under antiviral cover. So here's a straightforward progression to infection. You have a huge cobblestone papillae causing a shield ulcer. You can see the mucus plaque in the third picture and leading up to a frank infection in the last picture. Not everybody who has eye rubbing has allergy. Some people rub their eyes casually and habitually. Some people even rub their eyes to slow their heart. Yeah, you heard me correctly. Some cardiac patients with ectopics actually produce bulbar pressure to stimulate the vagus to reduce their heart rates. Here you see, this is a case of staphylococcal blepharitis. These patients also rub their eyes, so it is important to look at the lids as well. A small question helps sometimes. If you ask them how they rub their eyes, blepharitis patients will show you that they rub with a finger back and forth like this, whereas vernal or allergic patients use their knuckle and roll over the globe like this. Many times, dry eye patients present to you with itching as a symptom. But this kind of bilateral, dull, uniform staining in the interpalpebral area, we know that in allergy, the staining happens in the superior cornea where the papillae rub. Along with the fact that there is reduced tear meniscus and paucity of the papillae, you may be able to diagnose dry eye disease. I'll close with this last mimic where this boy was referred to us with a vernal catarrh because of the huge papillae and follicles that you can see in the lower lid. But then when you take a look at the cornea, you have corneal edema. We just saw that VKC is primarily an extraocular condition. And we dug a little deeper into the history, and he told us that some plant juice had squirted into the eye. Now you piece everything together, the inferior papillae, the conjunctival staining you see on fluorescein, which is inferior, coupled with that corneal edema due to endothelial toxicity, this is probably a toxic reaction to a noxious stimulus rather than any VKC. Because all the papillae that you may have, when there is no itching, there is likely that there is no allergy. So with that short list of differential, I hope I have somewhat covered the spectrum of allergic eye diseases. Thank you so very much.
Thank you so much, Dr. Natarajan. I think this was an exhaustive, and it looks like that I was seeing an atlas of spectrum of all these allergies from mild, moderate to very severe, and with all differential. Thank you so much for nicely covering that. Dr. Swati Tomar, would you like to make any comment on if there is anything else in the spectrum of the VKC or allergy? Do you want to make any comment on that?
So I would definitely, a very nice presentation, Dr. Radhika. It was amazingly concise, and I think we all should understand that there's a wide spectrum of allergy that we see here, starting from atopic to VKC with seasonal, with perennial, and every allergy has a different kind of presentation. And like you said, that if we delve into the history, there'll be a lot of important things that we'll be able to understand, like the last case that you showed, that it was probably not a VKC and would have the similar kind of features like a VKC if we disregard the history. So I think it's we can take questions if we want. It's amazingly concise, Dr. Radhika.
Thank you. Thanks so much, Dr. Swati. Dr. Sangwan, a quick comment on what you feel in your practice, the spectrum of allergy, and when you decide that, okay, this is something that needs my attention.
I think Radhika has presented a very good spectrum from very common to very unusual and very in the background of immune deficiency. Radhika, I want to ask you for the patient who had scarring and very extensive disease. Maybe you should investigate for something underlying. Because very unusual, there is a cystic degeneration or limbus, at limbus there may be a cystic degeneration, but having that kind of symbliphron and all that is very unusual. I have seen lid margin keratinization in severe VKC, which is persistent for.
So we did track back to literature, sir, when we saw one or two patients like that. The possible explanations were two. Literature does support that, you can have rarely this kind of, presentation. We did try and rule out underlying, like I said, you need to rule out, autoimmune secondary cell disease, which means the disease is active in those cases. And the only other explanation was a concomitant, viral keratitis, because HSV and VKC kind of
that
coexist
is what I
many
was
times.
thinking.
And cicatrization and dryness may be produced by, an additional component of HSV as well.
Yeah. Otherwise, it was
Great.
fantastic. Very good.
So great. I think for all general ophthalmologists, it's important that there's a variety of spectrum. They're mild, moderate, and severe cases, and you need to ensure that you rule out infection before you take these patients for any treatment. Yes, Dr. Sangwan, you want to add anything?
I just want people who are not seeing very often. The most important clinical symptom for the VKC is the patient will tell you that I have itching. You don't really have to ask. If you are trying to get the history of itching, that means you are dealing with something else. Otherwise, these patients usually will come and tell itching बहुत ज़्यादा है, and that should alert you. The diagnosis probably is not very difficult, but what you find clinically, how you decide it is active, not active, those are the things that we will discuss.
Yes. So allergy is a key factor. Repeat discharge is a key factor. As Dr. Sangwan said, that how do you actually diagnose and what are the signs and why those signs actually happen. So this will be taken over by Dr. Abha Gaur from Shroff Charity AIOS. Over to you, Abha. And our topic will be clinical signs. And if you zoom in those signs, what do you see?
I'm just sharing my screen, and in the meanwhile, can you see my screen?
Yes, we can see. You can make it PPT mode, please.
Yes. So thank you,
Perfect.
Dr. Vikas, for having me here. And after that very nice and a very elaborate talk, I'm just going to talk a little about the signs and what happens when you zoom in. So just zooming in into the signs, a very short note about how the patient presents. One is these are the common symptoms that you see. There is severe itching, there is redness and photophobia. The causes of these being itching would be because of the persistent sensation in the eyes because of release of the inflammatory mediators. This is often exacerbated by the rubbing of the eyes. Redness is because of conjunctival hyperemia and swelling of the conjunctiva in response to the mediators which presents as chemosis. Going to thick mucus discharge, this is often seen like a thick ropey discharge from the eyes, often during morning or after periods of inactivity. And photophobia because the child doesn't open his eyes very well and leads to squinting or closing of the eyes. The blepharospasm and ptosis may again be because of vigorous rubbing, deposition of the drops that we have prescribed in inappropriate cleaning, and ptosis may be because of the levator aponeurosis disinsertion or chronic microtrauma due to eye rubbing. Also, the giant papillae can lead to mechanical ptosis. Now, this is a child who presented to us in one of our centers in Uttar Pradesh, interiors of Uttar Pradesh, and he came with complaints of redness, itching, and watering. On examination, if you see, these are the typical signs. The upper tarsal conjunctiva shows papillae. There are some limbal pigmentation with limbal papillae. And if you see on higher magnification, there are Horner's, Tranter's dots as well. So coming to the first sign of VKC, which is the typical tarsal papillae, there is significant papillary hyperplasia, and it could be graded by the size of the papillae that you see into grade 1, grade 2, and the giant papillae that we see in severe VKC, which are greater than 1 mm. Multiple of these confluent papillae show a cobblestone appearance. And also there may be a membrane formation on these papillae, which cause the mechanical rubbing as well. There may be, if you want to see whether the papillae are active and there is active inflammation, you can also stain, which shows epithelial stippling on the papillae. And the common differentiation that you see where it is in between the atopic keratoconjunctivitis as well as the VKC, is that in VKC, they are most commonly located on the upper tarsus, and that helps in differentiating it between the other forms. The limbal papillae that we see again are more gelatinous and confluent, and they occur more commonly in the African and West Indian populations. There are white excrescences or the chalky white excrescences, which you see, which are the collections of these epithelial cells and eosinophils. And these cause changes in the superior to the superficial cornea, and also the enzymes released are epitheliotoxic and lead to corneal neovascularization. There is, yes, reported phoneal conjunctival shortening, and there is the phoneal conjunctiva usually would not show any shortening or symblepharon formation, which is against which would be the characteristic in a different form of conjunctivitis. So coming to the question that was there as well, there is a mixed form wherein both the bulbar and the palpebral form coexist. In the Asian and African population, the bulbar or the limbal form is more common, whereas the palpebral form is again seen in the Europe and United States. The mixed form is what features both the bulbar and the palpebral form of VKC, and this variant is more commonly seen in tropical countries, including the Indian subcontinent, with an incidence reported as high as 72%. So most commonly what we see in our population is the mixed form. Coming to the pathophysiology behind it, there is an overactivation of the Th2 cells, which further causes its hyperactivity and release of cytokines, particularly the IL-4 and IL-13, which cause hyperactivity of the B cell, releasing the IgE, which is the mediator, also cause the degranulation of mast cells, and cause release of the eosinophils and neutrophils from the vessels, causing cell migration and priming, and ultimately leading to formation of the these papillae. So basically, what you see as the Horner-Tranta spots again are localized collection of these eosinophils and the other inflammatory cells, the breakdown of which causes release of these eosinophil granular proteins, which cause the typical epitheliotoxic reaction, wherein you stain the cornea and you see staining patterns or SPKs. So there is release of myelin basic protein, the specific eosinophil-derived neurotoxin, which on release are epitheliotoxic to the cornea and hence cause the epithelial signs. There is also release of enzymes like elastase, which give this typical watery and the mucoid discharge. Also, the release of growth factors from the eosinophils, which is TGF-beta, the VEGF, and PDGF, which cause the conjunctival remodeling and the formation of these papillae. So this is typically what happens. And if you had to take if you had to do a conjunctival section of the VKC, this shows there is thickness of the collagen fibers and their irregular deposition. There is a deposition of mast cells and eosinophils, which is very typical in VKC because of the significant infiltration of these mast cells and eosinophils. There is also delayed type hypersensitivity seen because there is presence of basophils in these. And the goblet cell density, though, remains normal in the conjunctival epithelium of VKC, which is atypical, since they always the often increase in the other conjunctival inflammatory conditions. So this is a difference in the histopathology of the goblet cells versus the other conjunctival inflammatory conditions. This is another case wherein this child was a 13 years old male who presented with papillae as well as ropey discharge that you see in the first picture. And he also had been treated for systemic allergy elsewhere. He had a significant refractive error and a non-improving vision in one eye. If you see the conjunctival signs, again, he had Vogt striae and a keratoconus. You could see central thinning of the cornea, which was further confirmed on his pentacam. So at 1 month on treatment, the child shows signs of resolution, but then again, he presented with a recurrence and these typical corneal signs. probably the reason was that he had gone out and did not put his drops. But most commonly, the patients, what they complain is, it happens with the season changing. So another thing that you see are these SPKs, another corneal finding, which is the superficial punctate keratitis. These are multiple small discrete lesions of the cornea. They affect the epithelial and immediately adjacent subepithelial tissue. They can be looked for in fluorescein staining, and on fluorescein staining, you look for the location, size, and the pattern of staining, which helps you differentiate from the other causes of superficial punctate keratitis, which may be because of a foreign body or exposure or any other reason that you have SPKs on the cornea. On ASOCT, you can typically see that they show that the level of the lesion is epithelial. This was a study where we evaluated dry eyes in children with VKC using these clinical tests and the ocular surface analyzer. And we again found there was a short TBUT, which was significant, which showed there was continuing inflammation and also alteration in the mucin layer. There was a significant meibomian gland dropout and a reduction in corneal nerve density, which we have again confirmed on the confocal. So the top two figures show the confocal of a normal cornea, and the bottom two figures show the confocal of a VKC patient, a moderate grade VKC patient. So in the bottom two figures, if you see, there is a decrease in the density of the keratocytes. The number of keratocytes are reduced for the same magnification. And in the nerves, the density of nerves and also the branching of nerves is decreased. So that shows that the normal what we are finding on the histology is very well collaborated by the in vivo confocal microscopy as well. This is another case of an 8-year-old male who had presented with the severe papillae on the tarsal conjunctiva, giant cobblestone papillae, and on the cornea on examination, he had this typical lesion, which is a shield ulcer. He had also presented with itching, pain, photophobia, and watering in both eyes, and also gave a history of constant rubbing. So most commonly, shield ulcer in VKC is located superiorly near the visual axis. It is an epithelial defect with elevated margins. And yes, there is a high chance, if not treated, it could go in for scarring or infective keratitis over the lesion and ultimately have a decrease in the visual acuity. So the shield ulcer happens because of the mechanical rubbing, which is again a hypothesis, or the inflamed upper tarsal conjunctiva, which is rubbing, causes the punctate epithelial keratitis, which further coalesce to form a frank epithelial erosion. And there is fibrin and mucus deposition, which forms a plaque on the epithelial erosion, further leading to corneal vascularization and a shield ulcer. So the typical name that it gets is because of the shape that it takes of a shield, which is actually a protective mechanism, but it does have its there is a grading for it depending on prognostication, and I'm sure that will be discussed in the management as well. So just one second. So what we went ahead to do, most commonly, most of the pathophysiology is there on the tears. Tears is something which is in a child are very easy to collect. They are easily accessible, and they are also abundant in various biomarkers of the ocular surface. They also very nicely indicate the ocular surface health. So we took these tears, we collected the tears in Schirmer strip, in capillary tubes. We did the microRNA extraction and then analyzed them to know what is the actual pathology, that is, what is the molecular basis of the disease of the pathology that we are seeing. So what we understood from them is that we took both the tear samples and an epithelial scrape of different patients which were on medication and not on medication, only when they had to go in for a surgery. These were further tested, and what we found on these cells was there was a decrease in epithelial barrier function and increase in the inflammatory markers, which hence caused an increase in the oxidative stress and thus the increase in tissue damage. So just to end in conclusion, how is VKC different from the other ocular allergies? VKC generally presents in the younger age group, whereas atopic or is the older age group. VKC is more commonly seen in males, whereas AKC does not have a sex predilection. It is said to be of limited duration, but yes, there is adult form of VKC as well, though AKC is more chronic. The conjunctival involvement is more common in the upper tarsal conjunctiva in VKC versus the lower tarsal, and cicatrization is rare in VKC. There may be corneal findings in both, which are shield ulcer in VKC, and the corneal scar generally may not be vision threatening, though the scars in AKC are vision threatening. So with this, I would end. Thank you. And any questions are.
Thank you so much, Abha, for very nicely covering all the signs, be it papillae, Hornadanta spots, SPKs, shield ulcers. Amazing. I'm sure many of us have taken a lot of screenshots from your presentation. Dr. Amit, so what do you think that what are the signs that will, prompt you to start a patient for any medication, or when you say that, okay, now I'll have to take this patient for any medications? Dr. Amit, what are the key signs for you?
Thank you, because very nice presentations, both of them. And one comment I would like to make is what Dr. Radhika said. When I sit in the cornea clinic, we get patients referred from the OPD. And invariably, we get so many kids referred, and it turns out that they had blepharitis. So one message to the comprehensive ophthalmologist here is that whenever we say that it's such an easy clinical diagnosis to make, please do consider conditions, especially in children, something like staphylococcal blepharitis, which is easier to treat, and they may come with kind of rubbing and that kind of a thing. The second thing in practice that we find is there's a reluctance on our part to label these patients as atopic keratoconjunctivitis. Like somehow we stay away from that term. We will say advanced VKC, we will say, severe VKC. And here I would certainly like Dr. Sangwan's comment on it. So that because it's very important to clear that, because our management would, I think, change more towards systemic the moment we label a patient as having atopic keratoconjunctivitis. So first, if everybody could be clear and give their own opinions, and I'm sure everybody's experienced it, when do we label a patient as atopic keratoconjunctivitis?
Radhika, you want to say something?
You asked me, sir?
Yes.
Yeah, so I think that is a very, very valid point that Dr. Amit made, that both of Abha and I had said that when there is optimal amount of systemic involvement, optimal amount of ocular disease is likely to be VKC, even though VKC has got a more, florid stage. But in AKC, if you definitely see lesions in the skin, or skin does not mean only the cubital or the popliteal fossa, they can even be around the skin of the eyelid. If you see pigmentation, pustules, and like you asked, sir, if the patient goes for this kind of, cicatrizing kind of conjunctival changes, that is more likely to be in AKC than in Vernal alone. These are the patients who require immunological management in a larger and in a systemic scale rather than, with the ocular treatment that we give alone. In literature, it has even been documented to use drugs like tocilizumab. Maybe that is an extreme and anecdotal report, but that is the scale of treatment that sometimes is required, but not in every case. So AKC is more systemic and more severe ocular involvement.
So Amit and Radhika, my treatment is directed more towards the inflammation, what I see, irrespective of the diagnosis. So whether I label it a VKC or AKC, if I see a severe, moderate to severe inflammation in kids, I will put them on systemic steroids and oral cyclosporin or oral tacrolimus. And I'm sure some of the presenters will cover that area. So we will not discuss that part right now. Maybe, Vikas can point out that this aspect will be covered. But maybe where it's appropriate.
Yes, we have the treatment part coming up. So before just going forward, Abha, there's a question. Dr. Ravijit Singh from Amritsar asked that many times GPC can be presented even without any foreign body in the UTC. So what he wanted to ask is, what prompts that GPC formation? Although you have covered it, so can you just quickly comment on that? Can you please unmute yourself, Abha?
basically it is the presentation of whatever the allergen is. That is what is causing the release of the inflammatory mediators, and that in the conjunctival remodeling is ultimately, that is the papillae are ultimately forming because of the conjunctival remodeling secondary to the release of the growth factors like VEGF, etc. So that is what is causing the papillae.
So it says, yes, Dr. Sangwan. Dr. Sangwan, please.
This is for Ravijit Singh. See, any inflammation, any constant irritation on a mucosal surface, like you have when your shoe is pinching, you will develop a hypertrophy of the skin there, or you will develop a wart. Similarly, when you have a constant inflammation or an antigen antibody reaction subconjunctivally, so the microstructure of the upper tarsal cones is such that it will manifest in the form of a papillae, which may be small, medium, or large. So irritation can be due to suture, it can be due to contact lens, it can be prosthesis, it can be allergic reaction.
Great. So thank you very much, Dr. Sangwan, for nicely addressing that. And I think there are a lot of discussion on treatment part, and even in the comments, I can see that somebody has asked about the VKC and everything treatment. So let's move on the treatment part. So I'll invite Dr. Sahil Goel to talk on what are the medications available and how do you choose, what all do you take care of. Dr. Sahil Goel is an amazing clinician and a cornea surgeon from Ludhiana. Sahil, can you share your screen, please? So by the time he's sharing, so it's I think very clear that AKC or those severe things are generally taken care of by a specialist, for which Dr. Jayesh is going to talk on that. So that will also be coordinated, because I can see that there is some comments on that also. Sahil, can you share your screen, please, and unmute yourself?
Dr. Vikas, there's a question on bulbar pigmentation, the muddy bulbar pigmentation that stays even after the allergy has subsided. So by the time Dr. Sahil is sharing, can we?
Yes. So Abha, do you want to comment on that? So maybe because they have asked about the treatment part. So yes, Abha, you can quickly comment, and then Sahil can start.
Basically, like Dr. Radhika had also mentioned in her talk, there is inflammation, and there is increased metabolism in the cells, which causes these melanocytes to come to these spots where there is increased activity in these cells as well. And hence these melanocytes, when they break down, they leave the pigmentation there. So there was another question about whether it can be treated later on. No, it doesn't usually go. But it is because of the increased hyperactivity and because of the deposition of these melanocytes. Dr. Radhika, if you would like to add to that.
Yeah, same. The muddy conjunctiva is there to stay.
Yeah.
Great. Thank you so much.
Sahil,
yes, Dr. Sangwan.
About a melanocyte, I think the melanocytes in the skin, in the mucosal surfaces anywhere in the body, have a very interesting property, that each of the melanocytes, sends, their tentacles to at least 1,000 or more epithelial cells. And what their job is to remove the oxidative products, the waste products of the surface, so that the epithelium which is going to slough off, it goes away. In VKC, because as Avam pointed out, that there is a heavy turnover of the epithelial cells because the environment is very epitheliotoxic. So the stem cells have to meet that demand, and the melanocytes are not able to deal with that. So what happens is the epithelium moves with the pigment, and that muddy conjunctiva is going to be part of your structure. So there's no point chasing the treatment of muddy conjunctiva.
Great. So I think Dr. Nisha Bura, your question has been asked. So with that, Dr. Sahil, please go ahead.
Thank you so much. After this wonderful, I hope my slides are visible and I'm audible.
Yes, very much. Yes, very much. Please go ahead.
After this wonderful kickstart by Dr. Radhika, I'm going to talk about medical management of allergic conjunctivitis. We sometimes tend to ignore the effect of environment. The first thing we should always try to look at is the effect of dust, pollen, and heat. Besides, recent Israeli studies showed the importance of nitrogen dioxide, ozone, and particulate matter, particularly during stubble burning and Diwali, PM10 and particulate matter 2.5. All these have been recently shown to be of significant risk factors for exacerbation of allergy. Once we have ruled those out and tried to decrease the allergen or inciting agent exposure, we move on to the step-ladder protocol. Generally, nothing helps these allergic conjunctivitis patients as well as steroids. Lotipred, fluorometholon, this is like water to fire. Nothing makes the allergic patients as happy as these drops, and whenever we try to decrease, that's when they tend to rebound. That's when the first line comes in: antihistaminics, mast cell stabilizers, and dual-acting agents. When these fail to help, we move on to steroid-sparing agents like topical cyclosporin and tacrolimus. When the disease becomes resistant to them, that's when we go on to systemic therapy and biologics. I'm going to talk about them one by one and try to answer the questions which had been asked by the group or the questions collected. The first question was about steroids, fluorometholon versus lotipred. There is one randomized study in allergy and more randomized studies in refractive surgery patients, specifically PRK patients, comparing both. Most of the studies end up saying the same, that in terms of efficacy and IOP response, fluorometholon and lotipred are not very different. One additional benefit we get with lotipred is we get to titrate the strength 0.2%, 0.5%, and even 1% as lotimax. So we can titrate depending on how severe the allergy is. But in general, there is not significant difference in terms of efficacy and in terms of IOP response. So I think it pretty much comes down to surgeon preference. Now we have at least one fluorometholon that is FLOM available as bag-free and one lotipred available as bag-free. Most of the steroids, both lotipred and fluorometholon, are available with bag-free formulations are very limited available, specifically for children with dense ocular surface staining and dense SPKs. Coming on to the mast cell stabilizers and antihistaminics. A recent study by survey, this compiled, did not show significant difference in terms of various drugs. There was another 2022 Acta Ophthalmologica review article which tried to compare various drugs and surprisingly showed in terms of itching, of course, steroids always help, but mast cell stabilizers, antihistaminics, and dual agents generally are not significantly helpful. This is color coding where green shows the top most effective quartile and red shows the least effective quartile. What interestingly it showed was that topical NSAIDs, ketorolac, now recently approved cetirizine also, have been of significant help, and in most of the times they rank in first quartile for most of the symptoms, specifically itching, but also photophobia, foreign body sensation, and punctate keratitis or corneal staining. To the effect that, led by this 2022 article, I generally now tend to add ketorolac to whatever dual agent that I'm using. It could be olopatadine and ketorolac combination. It could be alcaftadine ketorolac combination. Interestingly, for macropapillae, it generally shows that, of course, besides steroids, cyclosporin and tacrolimus are helpful. Mitomycin, rarely used, can also be helpful. And triamcinolone, of course, also is helpful. Which drug we want to use between various mast cell stabilizer, antihistaminics, and dual acting agents is depending on what patient likes. You have to try various combinations, and based on patient experience, I would want, because these children generally would require this for 10 years every summers. So I would typically give them one or two antihistaminics or dual steroid agents and try to find out what the child is most comfortable with. But when these alone do not help, that's when we move on to the next class, that is steroid sparing agents in terms of topical immunomodulators, which mainly includes cyclosporin and tacrolimus. Cyclosporin is available as various concentrations from 0.05% to 2% in castor oil. Couple of randomized trials recently showed, and there was a new topical cyclosporin available as nanoemulsion, approved in US as 0.1%, showed significant benefit in terms of patient decrease SPKs and decrease itching for the patient. Problem with cyclosporin is limited bioavailability, and most of it tends to get drained into the lacrimal sac. The cationic in nanoemulsion was shown to have slightly better bioavailability. Interestingly, randomized controlled trial between efficacy of tacrolimus and cyclosporin showed tacrolimus to be slightly more effective. There was another study which showed cyclosporin resistance patients also tended to improve with application of tacrolimus ointment. Tacrolimus ointment available as 0.03% and 0.1%. It has been shown that 0.1% is slightly more effective, but also leads to slight more stinging and redness. If tolerated, we can use 0.1%. Otherwise, we have to step down to 0.03%. Both cyclosporin and tacrolimus act in a similar way. They are T cell inhibitors. calcineurin inhibitors, and that's why they are probably very effective for these allergic conjunctivitis patients. But when we see such giant papillae, the moment we stop steroids and topical drugs, or sometimes even on it, these papillae do not resolve, and that's when we tend to need systemic therapy. Systemic steroids cannot be taken for long. Such shield ulcer infection, they generally would require systemic steroid-sparing agents. Oral cyclosporin and oral tacrolimus being the first line. For milder disease, sometimes when associated with A2P, raised IG, we can use methotrexate, but generally we end up requiring cyclosporin and tacrolimus. Tacrolimus generally for kids would be 0.5 mg twice a day. Unlike cyclosporin, which has nephrotoxicity, diabetes incidence, hyperlipidemia, dyslipidemia, tacrolimus has lesser of these side effects. But when both of these also tend to fail something called recalcitrant, that's when we need biologics. There's very limited experience. Globally, there have been less than 24 reports which show omalizumab to be significantly effective for these recalcitrant or refractory allergic conjunctivitis patients. Some newer biologics like interleukin-4 and 13 antagonists like dapirolizumab have also been tried with reasonable success. Thank you so much. With this, I would like to end our discussion on medical management.
Thanks, Sahil, for an amazing literature review, and I think you have given all of us, a very comprehensive way of telling how many kind of drugs that are available. So, can you stop sharing this screen, please? Dr. Revati, would you like to make a comment on the drugs available and whatever Sahil has covered? Do you want to add anything to that?
Yeah, few comments. This NSAIDs, ketorolac, they were introduced quite long back, even before some of these dual-acting agents. And at those time, we tried, and we have not come across much help with these drugs. But I'm surprised a recent review showing that they are effective in symptomatic relief. But I'm not sure. Usually, I won't use these agents. I stick on to this dual-acting agents and antihistamines, and of course, chromoglycate and other things. And when we talk about these medications, it's not like, especially if you see an active VKC, it's not that these drugs will be tried first and then we will move on to steroid or other things, because most of the time we'll be seeing them with some structural changes also, like limbal papillae, upper dorsal papillae. So once these structural changes comes, means like they may need something more, like steroids in very active stage. Generally, I don't know, maybe the type of cases what we see here are different from what Dr. Sangwan and others talking about. Even with severe cases, I used to go only maximum up to loteprednol, maybe from twice a day, little bit more, and then bring it to twice a day for a longer time. But it's very rare for me to even go for a dexamethasone or other steroids, topically also. And systemic, very, very rarely I used to use systemic steroids, pulse therapy, very rare. More than that, I used to introduce this cyclosporin or tacrolimus, always, even with or without steroid, even when I am tapering and stopping steroid. Before that, I add these things constantly to all VKC patients. If it is some other allergy, it's different. But VKC patients, even with one of the dual-acting agents, we have to. And what Dr. Sahil pointed out about the dual-acting agents, he is correct. Many patients, it's like artificial tears. They will choose one by themselves. So whichever they are comfortable with, I just go along with that same medication. I don't change them unnecessarily. This is how, like, very rare for me to get such patients who will need systemic severe immunosuppression or even topically a stronger steroid. But of course, supratorsal decadron and tricot, I used to give for shield ulcers and other things, provided they are not steroid responders.
Sure. So what you're trying to say is steroids, antihistaminics or dual acting, and lubricants. These are the three things. Dr. Basak, you're there. Would you like to tell us what is generally, how do you manage, what are the kind of drugs that you use? Okay, by the time Dr. Basak is saying, so Dr. Sangwan, there are a few general ophthalmologists who are saying that that's fantastic. It's really great to know all these drugs. But in a layman language to a general ophthalmologist, what do you say that how do you how one should manage, what drug to be chosen, and how do you follow up? Do you want to make a comment on that, Dr. Sangwan?
Yeah. First of all, what Revati said that we may be different. In our practice, we may be seeing different kind of cases, which is very true. Mostly patient which I see would be more referral with little more advanced disease with structural changes. If you are general practice in a smaller town or a taluka level, then you may be seeing very naive or virgin cases. They will respond to topical steroids and mast cell stabilizers. So for me, what Revati said again, very true. Nested, I don't use at all. I don't think they are effective. Their reviews and all that, they just keep recycling the same knowledge in the literature. Number two, any patient who has itching and telling the child that, oh, don't rub, doesn't work. And when we have itching, you will realize that if somebody tells you don't rub, how you will feel. It basically it's a immunologically driven chemical mediated disease. So you must control that inflammation, and for that the role is only of these 2-3 medications, steroids of different types depending on the severity, as a pulse dose, a mast cell stabilizer throughout the year, and tacrolimus for me now is standard for all except very mild disease at bedtime as an ointment.
So, Dr. Sangwan, no NSAIDs, steroids based on severity, either fluoromethalon, loteprednol, or Predford. Antihistaminic, you are saying either
and as a pulse dose, meaning you may, depending on the disease, you may taper very slow. You may, if see very severe disease, then you hit with very hard with predacetate. If it is a mild disease, no structural changes, only itching, you FML loteprednol is perfectly fine.
So if only itching, you are giving a lot of importance to itching. So if it's itching, you would like to treat only itching, maybe fluoromethalon, structural changes, maybe loteprednol or Predford. And then you have said that antihistaminic like olopatadine you are going to give throughout that season, and along with that,
not season. No, not season, throughout the year. So I counsel the parents that do not stop medication even if there's no symptoms, because it is these drugs, mast cell stabilizer and the tacrolimus, they are best as a maintenance drug. And the better during it is controlled, less breakthrough attacks, the better, easier to control.
And do you want to make a comment on cyclosporin? Do you want to use, and when do you want to use cyclosporin, if at all?
Cyclosporin I used long back when these commercial things were not available. Now almost exclusively I use tacrolimus ointment. I find it's very convenient in terms of dosing and effectiveness. So I don't make, earlier I used to make 2% cyclosporin for many years, custom made. Now I don't make cyclosporin drops.
Dr. So, a small addition to what Dr. Sangwan said is that I think Sahil touched upon the point that while tacrolimus is very effective, sometimes you need the higher dose, but then the 0.1% sometimes cause ocular surface irritation. So recently there is a publication in IGO by Dr. Vanti's group where they show that the over-the-lid eyelid application of the higher concentration of the tacrolimus gives the desired effect. It boosts the treatment, but at the same time reduces the contact-related irritation.
Yes, that's Radhika. That's precisely we do in apply on the skin. If the child does not tolerate, that is very, very helpful.
Great. So I think Dr. Amit Patel, what question he asked, you have already answered that. Olopatadine or antihistaminic you are going to give throughout, lubricants you are going to give, and the different stage, the steroid will change, right?
Yes.
And steroid you will give only in pulse therapy, maybe 20 days, maybe 30 days, and then you will switch it off, right? And cyclosporin maybe sometimes when you want to use it as a steroid sparing agent, correct?
Yeah.
Okay, fantastic.
One more thing, Vikas, I think even the tacrolimus part has to be there in the maintenance also. That's what Dr. Sangwan mentioned. The steroid is for pulse, but along with the antihistamines, the tacrolimus part also should continue. In
Dr.
Structural change.
Himanshu,
in big case.
Yeah, sure. Himanshu, do you want to add anything to that, Himanshu?
1 minute.
I just wanted to make one comment that one thing I think we have to understand the disease process, that once the disease starts, whenever there is itching or active disease, there is no other way to stop disease, but to use topical steroids. So if, as Dr. Sangwan was saying, that if somebody comes with a mild recurrence also, you have to hit with steroid. Now, there can be different strategy, whether you use low dose steroid for longer time or a jab of high dose steroid, which for a shorter time, that's fine. But unless you use topical steroid to control the inflammation, you cannot control the disease, because that's the vicious cycle which you get into. And so wherever there is recurrence, and that's where Dr. Sangwan's one point was very important. We have to convey to them that do not stop the medication till you see us, and usually prescribe more than your next follow-up call. So if your follow-up is 1 month, give medications for at least 40 days. So that if they come little late, they don't stop it and then again get a recurrence, and then you have to start the entire cycle again.
Great, fantastic. Dr. Swati, would you like to see anything before starting steroids? What is your protocol?
So mostly if it's kind of a seasonal, this without any exacerbation, I would not put on steroids, but put on lubricants and dual acting like a mast cell stabilizer and an antihistaminic. But definitely if there's an acute exacerbation, if it's a child and a lot of itching, as Himanshu said and Dr. Sangwan said, definitely a low dose steroid, a loteprednol would help, a short duration, and probably taper it as fast as possible.
Okay, one last question before we start with the next question. Next, Dr. Amit can answer that question. So there's a recently companies are promoting Ectoin for allergy symptoms. Do you have any experience with that, or what do you any comment on that Ectoin?
No, I lost you for a second. Can you repeat it?
So there has been new molecule called Ectoin, ECTOINE. So do you have any experience with that? Soham is asking that question.
No, I have no experience with that.
Anyone on the panel have any experience with that? Okay, great. So, Dr. Amit, you wanted to make a comment, please?
Yeah. I'm pretty bullish about giving oral, antihistaminics for a short time. And we have been trying oral belastin with very good results in children who can take. I find it to be more effective than, just normal kind of an Allegra, Allergic kind of a syrup and stuff like that. So I do give it for a short time because very mild cases do not present to big practices like ours. But once the child has more severe constant itching and you want to relieve that itching, like Dr. Sangwan was saying, it's sometimes not a bad idea to give anything what you're comfortable, cetirizine or fexofenadine or belastin or whatever, but give it for a short time, and that maybe that will decrease the need for steroids in these patients. So sometimes, but give it for at least 2-3 weeks or something like that, so that the allergy settles down in the child. That's what I like.
Perfect. Thank you so much. And then there has been talk,
one comment,
about
very short comment, because
yes, please.
what I meant, the difference in presentation in Aravind, of course, we are seeing almost, we are covering the Kerala, northern part of Kerala, where severe allergic diseases are very common. They used to come with a typical VKC, even with GPC, all those things. But still, I rarely come across a patient who will not respond to this medication, this maintenance and other things, and going for a higher level of systemic medications. It's very, very rare for me. Maybe another thing, like as I said, the presentation itself, it must be different in different parts of the country. It's quite possible.
Perfect. So maybe I'll summarize for the benefit of our audiences that allergy, the VKC or allergy has to be treated, and you have to give prophylactic medication. For treatment, there will be steroids of different, based on severity, and prophylaxis will be either antihistaminic or tacrolimus, and that will go for a long time. So we have talked about rubbing, we have talked about shield ulcers. So let's see what are the non-medical treatment that is available for VKC. For this, I invite Dr. Sharon D'Souza from Narayan Netralaya to start her talk on that. Sharon is a very eminent cornea surgeon and immense experience in allergy. Over to you, Sharon.
Good evening, everyone. Are my slides visible and am I audible?
Yes, please.
Right. Good evening, and thank you, Dr. Vikas and AIOS for this opportunity. So we've had a great set of talks, and it's been very interesting. The lucidity of the thought, and that's what hopefully we can carry through. So when we talk about non-medical management, it sort of reminds us of like a condiment for a meal, or the add-ons or the sides of a meal. But what we all know through our practice is these non-medicals sometimes are as important as, say, adding salt to get a nice, tasty meal. So what are these non-medical managements of ocular allergy? So the management of allergy overall includes, of course, the pharmacological treatment, which was so beautifully covered in the previous talk. But there are also a lot of other additionals like adjunctive measures, including protecting the eyes, avoidance of allergen, which I'll be talking about, counseling, chair time, and of course, some therapies like immunotherapy, which are also, have an important role to play when we are looking at the entire spectrum of disease. So let's see where each of these fit in. So adjunctive measures, there have been enough and more literature, and we've seen it even in our practice, that it's because allergy is so rampant everywhere, we see it so common, and it's very difficult to identify what is causing the problem. So protective measures like protective glasses do help a lot, especially with children or even adults, because it reduces the direct exposure of the ocular surface to an airborne allergen. Another thing which I have found our allergy specialists to recommend quite often is to maintain an allergy diary. And that basically is for the parents or the adult to note down what they find in their day-to-day activities, be it some exposure, some activity, some place they visit, or rarely food, and what is triggering it and how bad that episode of allergy is. And this helps them sort of realize what could be making it worse, and then go into some avoidance measures or lifestyle changes if we can identify the direct allergen just by this simple means. And believe me, there are people who have even changed where they live. If they have pets, there's a change in that. So there are things we can do, including using what kind of covers that can be used. Nowadays, you get a lot of dust mite protective covers. So there are our lifestyle changes which can be very, very useful, and especially with children, as very nicely put, it's very difficult to say don't rub the eye when the eye is itching. So we have to try and prevent or reduce what is causing the itching, either by avoiding it or protecting the eye itself. One very, very important point, which I think is valid here, is there is a myth or sort of a misunderstanding. Especially a lot of parents will say, the child, we don't even send the child out, but they're still having allergy. And this is something which is very important to understand, that even though seasonal allergies are often caused by outdoor allergens, perennial allergies are very often by indoor allergens. So it's not necessary that if the child is not going out, they would not have allergy. And typically these are IgE mediated allergies, so they can happen. It's a type 1, it's a very fast acting allergy. The next is role of cold compress, and this was one of the questions which was important, and it's true. So cold compresses have been tried even in non-ocular allergies, skin allergies. It does reduce the inflammation and itching quite effectively and quite fast, and it does this by decreasing the blood flow to the area, hence reducing the congestion and inflammation. It reduces the release of histamines, and of course we know that histamines do trigger the itchiness. And one very important thing is it blocks nerve impulses that trigger allergy symptoms. And one thing we can tell our patients, of course, is to put cold packs. But another important thing is if they can keep the drops in the fridge door, then even using a cold drop can give them a lot of comfort. A cold lubricant drop could give a comfort. So this has found a lot of use in newer research, and one of the things is that the TRPM8 channel, which is very important for cooling to relieve the itch, is actually being tried out as a targeted immunomodulation in research right now. So these kind of non-steroidal or non-medical means are also extremely important. Coming to, these were for the milder forms of allergy, but once we reach the more advanced forms, we do know that sometimes the medical management may not work for these conditions. So we do need some procedural or minimal intervention for these conditions, and the most important being when we have giant papillae and shield ulcer. So identification of an early shield ulcer, of course, is as important. It's, once there's a large ulcer there, it can be picked up, but very often it may be as subtle as the, clumped or confluent punctate erosions on the superior mid-periphery that you need to pick up. Important is that you have to continue all the other management measures, and it's not a be-all and end-all that you gave the injection and the eye is going to recover. Very importantly, we have to check steroid response by giving some topical steroids before planning an injection, so that we're not left with a child who has a depot of a steroid there and intractable glaucoma, which can have its own set of complications. So how do we do this supratarsal injection? One is, of course, we use our anesthetic, which is proparacaine. You put it in the eye, then evert. Use a cotton tip applicator, which is again soaked in the anesthetic and placed on the area where you're going to put the injection. A regular 26 gauge needle can be used. Very fine needles can get blocked because of the triamcinolone is a little thick. And the site of injection is, once you've everted the lid, you go about 1 millimeter above that edge of the superior tarsal border and inject it. The conjunctiva should not balloon up. That's how you know that you're in the right space and not just subconjunctival. It's fairly easy to do in an OPD setting, so can be done. Of course, once it gets worse, there's an actual ulcer there, then we have to debride it by, take it into OT and debride. And this may also require an amniotic membrane graft along with it. And just to show a very small video, it's not at all difficult to do. You can use any sharp or, semi-sharp instrument, whatever is comfortable, and then debride it till you can remove those plaque-like structures. Depending on how long that shield ulcer has been there, you may or may not be left with a clear base, but you're just trying to remove as much of the plaque as possible. And if required, if it's a very large area, you may even need a amniotic membrane to help the healing faster. The great thing is that over time, you can get very effective results, both in the reduction in size of the giant papillae. Not always possible. If it's a very chronic papillae, then it's already gone into scarring. You may be left with the flat top gelatinous appearance. But if caught early enough, you can have a reduction in the papillae as well. And of course, we all know how beautifully the cornea can remodel. So even the scar in many of these children does reduce. Very, very importantly, we have to understand that it's not just the injection which has acted here, but it's everything else, whatever has been discussed in the previous talks, including the tacrolimus, using the topical steroid at the right time. Sometimes we may have to use oral steroid or other medications, depending on how severe and how chronic the disease is. So I just wanted to add one point here. So we all always focused on the severity of disease. And of course, VKC as a disease can cause sight-threatening problems. So that's always a challenge. But a chronic disease, which is not so severe, but keeps coming back with recurrences, can also be very troublesome for the patient and the parents dealing with it. So we always have to find ways to reduce not only the severity of the disease, but also the frequency with which they have exacerbations and acute episodes. So our entire treatment is geared to try and deal with that. Immunotherapy is something that we've used in our practice, and I just want to share a few slides on that. Most importantly, it is recommended in cases where you have chronic recalcitrant disease after using all these treatments that we've already discussed. And the way to start the immunotherapy is that it's not based, one very important thing again, is it's not based on serum IgE or our blood levels of IgE or absolute eosinophil count, but actually on the actual allergen that might be triggering it. So the way to test it is skin prick test or a specific IgE, which is not available clinically, and patch test. But of these, the skin prick test is most important. And this is done by an allergy specialist. Based on that allergen testing, the specific immunotherapy would be started. And the most common, again, for ocular allergy is the sublingual immunotherapy. Again, an important point to remember is that the allergy specialist will base their decision to start a sublingual immunotherapy on the fact that this person may have very severe disease, they may have other systemic allergies, and they have to have a positive skin prick test with either one or two allergens which show a hypersensitization. If there are multiple allergens which are showing hypersensitization, as can happen in many of these diseases, especially A to B, then we cannot give an immunotherapy to this. So it's very easy to do. It's placed sublingually and once daily for 3 to 4 weeks. Important again to remind the patient there may be an initial exacerbation followed by a gradual desensitization. We found very interestingly that the need for topical steroid in patients who had multiple episodes of recurrence did come down significantly, as is the oral steroid requirement. Of course, topical immunomodulators like tacrolimus was across, they were continuing across this management. So it didn't reduce much, but very gratifying to see how many we could manage, get them off the need for topical steroid. The last thing I'll be highlighting is, of course, when we're looking at eye rubbing and allergy, we realize that a lot of patients could have keratoconus and the association is very, very strong. And this happens because the eye rubbing itself triggers a lot of physical corneal change, resulting in the change in the corneal shape and also the pathological changes because it releases matrix metalloproteinases, a lot of inflammatory factors which trigger more itching and allergy on the surface. So a large proportion of these patients can have allergy and eye rubbing. And what is interesting is that 27% or so of patients of keratoconus had VKC. And similarly, among the keratoconus patients, among the VKC patients, about 24 to 28% had KC. So this is the actual numbers. We're looking at a very severe allergic disease in KC patients. But through our practice, we've all seen these cases of patients with keratoconus who had very minimal or very low signs of allergy, but still feel like rubbing their eyes. And that is something which is extremely important to remember, that even if we don't see too much allergy on their eyes, we can still have itching. And we published this paper where we showed that it is the ocular surface IgE which triggers this need to rub, even if we don't see allergy. So it's important to treat that allergy as well. So if they are complaining of eye rubbing, even if we are not seeing a typical, very severe allergy on the surface, it is important to treat that so that they stop rubbing. So the aim of our treatment is, of course, to reduce the severity of disease, reduce frequency of exacerbation in acute episodes, avoid complications from disease itself and from the medications to reduce the dependency on steroids as much as possible. Adjuncts, add-ons, be it cold compress, protective measures, avoidance are very, very important. And of course, as with any of these chronic diseases, counseling the parents or the adults for expectation of outcomes and prognosis and the need for multiple follow-ups is very, very essential. Thank you very much.
Thank you so much, Sharon, and special thanks for setting up the stage for our next talk also. You have covered rubbing is very important to deal with because it can cause keratoconus and ice compresses you have covered, and shield ulcer management. There are a lot of questions on that you have already covered. One question for you. Dr. Ravijit Singh is asking that, have you tried to change the geographical location of a patient in case of severe allergy for maybe limited period of time?
I have not tried it myself, but I do have a patient who actually moved because they felt that that area where they were living in was causing an allergy. So it did help in that case. I don't know, it seems very extreme for us to advise it, but maybe in very severe cases. But we know that it can be, depending on what plants are around, what if there's construction around, things like that do definitely make a difference. Yes.
True. So we all know that we have seen patients who sometimes they go to another place and then say that I had gone to Switzerland or Canada and now it's fine. Dr. Amit Gupta, can you make a comment on the last talk, please?
Yeah, I think it's such an important topic because we face that, the parents say, okay, fine, we say change the environment, change something. What do we do about it? So one thing is whether the use of air purifiers and air conditioning helps in these patients. They have filters in the AC, the air is getting filtered and some people feel better. And some of these children might feel better within those kind of air purifiers working around the clock inside the room. And but when it comes to the IgE and immunotherapy, once it is, I think, fairly expensive, I think, to do it. And I'm a big fan of trying to identify the IgE levels in these patients who are severe. And we have a fancy machine in the immunopathology department. They run multiple panels but somehow we've not been able to solve this mystery of having the severe VKC and correlated well. Some patients with very severe VKC actually do not show raised IgE levels. Yeah.
Can I just make a point?
Thank you.
So one very important thing is that if you look at seasonal and perennial allergies, they are primarily IgE driven. VKC has both IgE driven and non-IgE driven pathologies. So I agree with you 100%. A lot of patients may not have, even though they have severe ocular allergy, many of them do not have raised IgE. It is absolutely true what you pointed, which is why we the treatment cannot be based purely on the serum IgE, and
Correct.
we don't. So doing that test just tells us if they have a high IgE, we know that they have some raised hypersensitivity in the body, but none of the treatment gets based on that, not by us nor by the allergy specialist, is what I have understood over the years that I have worked with them. So
Great.
Dr.
Thank you so much,
Vikas,
Sharon. Thanks. Yes,
Dr. Vikas,
Depriya.
we have a question. When should the VKC patient be referred to a dermatologist, or do we at all, like how do we decide on that?
This question is going to be covered by Jayesh. So we are going to start a very interesting talk after Dr. Sangwan's comment. Dr. Sangwan, there's a question for you is that in brief, how do you manage shield ulcer, or should shield ulcer be managed by a general ophthalmologist? And second question to you is, for how long do you continue tacrolimus in any patient?
Tacrolimus, I will continue, as I said earlier, throughout the year. Many doctors have this concern that does it cause side effect? Is it safe to continue? I think there is no problem in terms of the continuing it. And my goal is to get the child symptom-free at least for a year or 6 months, recurrence-free. As far as the shield ulcer treatment, I would, if the general ophthalmologists are comfortable, grade 1 shield ulcer with clear base, that can be treated aggressively with topical steroids and supratarsal steroids with or without AMG. Most probably in grade 1, you don't need AMG. BCL should be fine. More than that, maybe it's better to refer because what looks very simple in Sharon's hand may not be very simple for a general ophthalmologist.
Great. And Jayesh is going to cover that.
One comment I want to make. Sorry, one comment about shifting or suggesting to shift the location. I think this is should be done very cautiously. Only the patient whose parents are affording. Otherwise, you can create guilt among parents that, oh, we are not able to provide treatment to our patient. We need to shift Simla or Canada. We can't go, and therefore our child will suffer like that. I think this is not a very good idea.
I think what sir is saying is so true about this guilt of patients, because very often the parents become so involved or invested in that child's disease that they are trying whatever possible, and we have to sort of temper that. As I said, even this one patient, they wanted to shift, but otherwise it is definitely not recommended. And the same thing with having air purifiers throughout the day and things like that. It's not at all, there's no basis for it. And there's this very nice article, of course, it relates to general allergy, where they have taken each of these questions and put down a recommendation based on how highly they recommend it or low recommend it, and nobody recommends that you should have such extreme measures.
Yes, thanks, Sharon. So what
just
goes on
one
in the
small
patients?
point, Dr. Vikas, about the
last 30 seconds.
Last point is about the cold compression. I think I'm very glad that Sharon highlighted it, because a simple measure we tend to overlook sometimes definitely adds to the management, but should also caution the patients not to keep ice on the eye. When they keep it directly on the eye in the form of ice cubes, I've seen patients come back with necrosis of the lid skin and secondary complications. So that must be told. They go take it to another level sometimes.
So that's what next talk is all about, counseling. Dr. Himanshu Matalia, I think he's the best person to address that. So let's move on with Dr. Himanshu's talk. Himanshu from Narayana Netralaya, amazing cornea surgeon, dear friend. Over to you, Himanshu.
Thank you, Vikas, and very good evening to one and all. So when Vikas told me that talk on counseling, I found it really silly that how can you have a talk on counseling? I mean, that's silly to make a presentation and talk what we should be doing. I still did that sin and I still made a few slides. So when we talk about counseling, first most important tenet of counseling is be truthful. As a doctor, first thing you have to do is be truthful. But it does not mean you need to be rude and insensitive and harsh. You still can be truthful and you still can convey whatever you had to convey. Many times, there are certain aspect of this disease is something which you have to convey. Now, another part of the counseling is taking many times we discuss that patients ask a lot of questions, they read internet. Well, for you, it's same available internet out there very well, and there's absolutely no beating around bushes. Now, when we talk about the problem of allergic eye disease, there are certain things which we should be included in our counseling. One of them is chronicity of the problem. We must tell them how chronic the problem. We must inform them there would be multiple recurrences expected. We must tell them that we should be finding out, or rather we should do our best to find out the root cause, because if we do not treat the root cause, the disease is very difficult to treat. Self-treatment is a bad idea. We must convey to them. We also discussed that we should tell them that not to stop the treatment before you see the doctor back. And same time can tell them that, you know what, there is something called tolerance. And after a while, the disease may die down in many of them, and some of them it may continue. We discussed that we must tell them to not rub their eyes, and the regular follow-up to see other things like intraocular pressure, cataract, and all those things, infection is very important. With this thing, let's go live. I was talking to Vikas and Swati. I said, I really don't feel this is the right way to take a talk on counseling. So what I did was, one patient came and I recorded the counseling part of that thing. Because of the paucity of time, and may not have been able to include everything, but this is what first question what she asked, that I have this problem since long time, keep coming back, frustrated, when it will stop. So we start with the video.
Hi. Good morning, ma'am.
Good morning.
How are you?
Fine.
Tell me, how can I help?
I want to ask, like, I'm having allergy like since long time, and it's coming like frequently, like every month and weekly also. Like past 2 months, I'm suffering like weekly this problem. So mainly what I'm saying, like in Bangalore, I'm having this problem is more. If I will go my native place, so this problem will not there. So like how I can recover for this allergy?
Sure. So, few things we will talk about allergy here. So when you said that you have a problem of allergy, I understand that you have itching of the eye and you have typical redness of the eye and eye rubbing and everything. And these are typical features of allergy. When we say allergy, we have to understand one thing, that it's a chronic disease. It's not going to go anywhere. It's a very long-term friend of yours, and it's going to last very, very long time. Second thing, we have to understand allergy is not a disease. Allergy is exaggerated immune response. It's your normal immune response. By immune response, what we mean is your defense mechanism of body is trying to fight against any terrorists which are entering your body. Now, ideally speaking, your defense mechanism should be fighting against bacteria, viruses, and those kind of things. Sometimes what happens, they start fighting against something which is not as dangerous and which is exaggerated immune response. And that's what allergy is about. If I give you an example, this is like that Bajrangi Bhaijaan movie. I don't have any financial disclosure yet, but if you've seen the movie, that one small girl crosses India-Pakistan border and army is after that girl to catch and something. Now that girl is not a terrorist, right? But again, the army is after catching that girl, and that's exactly allergy is about. A small dust particle, pollen particle, which enters there, which is not as bad as a COVID virus or a bacteria or something, but your immune system behaves as if there is some big enemy out there, and they go and start fighting. Whenever there is a war between immune system, your antibodies or your immune cells versus any antigen which is coming from outside, any protein which is coming from outside, the battlefield suffers. Wherever they meet each other, that's where they throw bomb, and that's where you have the battlefield, and that's where you get problem. Now, there are very few parts of our body which are exposed to outside. One of them is eyes, second is nose, third is your mouth, and then your skin. So these are the areas where you can have entry of outside things, and hence allergy may manifest in these places. Right? So if allergen goes from your nose, you can have frequent sneezing, you can have frequent cold. If it goes through your throat, you can have bronchitis. If it goes through your eyes, you have allergic eye problem. Right? So as I told you, that this is like that Bajrangi Bhaijaan movie, a small child crossing border, army after that. Interestingly, with all the treatments, whatever we do, we are just putting our soldiers to sleep. We are just reducing the activity of our immune cells. Now, if you remove soldiers permanently from the border, well, some actual terrorist can cross the border, and that's dangerous. So we cannot permanently put them to sleep. We cannot permanently give you steroid drops, which can have its own side effect. So we have to stop these drops. As soon as we stop it, and if the child is still crossing the border, those army guys will get up and again start throwing the bomb. So as soon as we stop the drops, and if the allergen which you are allergic to still there, your immune system will still react to it and you will have recurrence of allergy. So if you logically think about it, it can get only cured if we are able to find out which child is crossing the border and stop the child there. If we are able to find out which allergen is causing allergy, and if we are able to stop it there, and then only we can cure it permanently. Or if your body understands that, you know what, this is fine, it's okay, it keeps coming back, let's just accept it. And that's called tolerance. At long term, some people can develop tolerance, and especially in kids, usually around adolescent age, they do develop tolerance. But sometimes they may not develop tolerance and the allergy can continue for a long time. There are few allergies, and you rightly asked me that when you come to Bangalore, you get this thing. That means that something which is related to the Bangalore environment or your house where you're living there, where you are having allergens and which is leading to allergy. Some of the allergies are perennial throughout the year. That means that allergen is there throughout the year. Some of the allergies are seasonal, like some of the pollens, and they possibly would come when that particular flowering occurs. So these are seasonal allergy. Some of the allergies are episodic, like your allergy. When you come to some particular place, you get allergy, and which possibly explains that that particular allergen is responsible for your allergy and it's there during that particular season.
So the next question was, apart from medicine, what more can I do? And I think majority of the part which Sharon took over.
Apart from medicine, like what can I do to avoid this allergy, and how, like I want to know like from which thing I'm allergic, that like how like I get to know.
True. So it's a very interesting question and very important question when we say that what more we can do apart from medicine. As we know, the allergy is not a disease. It's not about medicine. It's about finding out what you are allergic to, the allergen which is responsible in your case. So one important thing to remember is to be more vigilant and find out what you are allergic to. It may be very difficult. It may be difficult like trying to find a needle in a haystack, but still not impossible. There may be some indirect suggestion which you may get from your allergy. Remember, if somebody is allergic, like if you are allergic to dust, and if I come to your house and if I start dusting there, you will start sneezing there. Will you start sneezing immediately or after one day? Immediately, right? Allergic response comes within minutes. Remember, so when the day you start sneezing, the time you start rubbing your eyes, itching your eyes, think about it. Where were you probably 15, 20 minutes back, which may give you some idea. Now remember, if I give an example, if you start getting allergy when you get up from your bed, that means you don't need to blame environment and pollution and all those things. That means allergen is around your bed. Most common allergens in our country One of the most common allergen is dust mite, right? House dust mite, what we call. Second, you can have something like cockroach particles or cockroach antigens. You can have something like mosquito wings, mosquito particles there. You can have pet hair. You can have, typically pet hair is cat hair, and dog saliva can be more antigenic. Many times somebody can be antigen, somebody can be allergic to certain plants, some food and something like that. But coming back to the same thing, that we should maintain an allergy diary where we can write on the day you get allergy, what food you had previous night, or what food you had that particular day you should write down. Where were you should write down. If you start documenting, you may realize that every time there is something which is common and which may give you some idea. When the allergy starts, it starts within minutes. So be aware that when allergy starts, where were you, it can give you an idea. As we were talking about the morning allergy, we can do few things like dust mite related allergy, which are typically around your bed. So the place where dust mite can actually stay is one is in your pillows. So somebody with frequent allergy, you might want to avoid those cotton pillows. You might want to have fiber pillows, which are washable. You should wash your pillow cover every week. Your bed sheet should be washed every week. Avoid using fleece blanket. Use cotton blankets, which can be washed. For kids, we use that cover to cover the mattress so that they don't soil the mattress. Well, you can use those kind of cover to cover your mattress. Again, if possible, avoid cotton mattresses. If you have a chance to buy a new mattress, make sure you buy those coir and those kind of things which are tightly covered on the surface, and you can put one extra protection cover on top of it, which prevents any dust mite which are living there to come out. Remember, when we wash our clothes, we dry them inside the house rather than outside the house, because you do not want dust to again gather on top of it. Remember, like how we put our expensive saris and those covers and those kind of things, it may not be a bad idea if somebody is allergic to put their clothes in covers and put it in the cupboard. If your child is allergic, make sure that you inculcate habit of washing the hands, washing the face. When the child comes from the school, make sure they remove the dress and get into a wash pair of clothes. When they go out to play, let them play in this thing. When they come back, make sure they get into a wash pair of night dress, right? Remember, if you want to get rid of the dust mite antigens, house dust mite, they can only be killed if the temperature is more than 60 degrees. So around 60, 65 degree temperature is required. So if you are using your washing machine and if it has temperature, make sure you use that 60 to 65 degree temperature, which can kill the dust mite. Right? So these are the things which can help to reduce the dust mite. Also, where there is more dust mite can live there. The other place where you can have more dust is your curtains. If you have curtain at home and if you're washing it once in a year, maybe once in 6 months, you can wash it. In Indian condition, it may not be needed to use your carpet. Carpet has maximum amount of dust. So if you have carpet, if you want to get rid of that, it may not be a bad idea. If your sofa has a cloth upholstery, and if it's possible to change it to a resin or a artificial leather, you can change it to it, but at least make sure you clean it. It may not be a bad idea to do a regular deep cleaning of the house. If you have a vacuum cleaner at home, make sure you utilize them, because sucking away the dirt is much more efficient than sweeping from one corner to another corner. If you want to invest in a air purifier, it's not a bad idea. You surely can invest into an air purifier, but please remember, it may not be able to get rid of all the antigens possible. But using all these tricks may help you to get to possibly find out what you are allergic to. However, there are allergy specialist allergy tests which are possible nowadays and which can be done. They do certain tests on your skin and in the body and may be able to tell you common allergens. And these are called allergy specialists. You can talk to your doctor and they can refer you to an allergy specialist. And as a eye doctors, we should be in contact with allergy specialists, somebody whom you are comfortable with, who can help you to find out what that person is allergic to.
So I don't think I'm going to take that eye rubbing part of it. Everybody has spoken about eye rubbing, and the only one part of eye rubbing which I would like to convey is there's something which we keep forgetting, which is the indirect eye rubbing. And indirect eye rubbing is something which we must pay attention to. Indirect eye rubbing is where while sleeping, if we keep our hands on our eye or upside down when the pillow pressure on the eye, that's much more dangerous than having just direct eye rubbing of few seconds. That doesn't mean you allow direct eye rubbing, but pay attention to indirect eye rubbing. Unless proved otherwise, asymmetric disease, asymmetric keratoconus is related to indirect eye rubbing, which if you miss out may lead to continuing problem. Yeah, thank you, Vikas.
Fantastic, amazing. I think Himanshu, beautiful line. I think it's very important. Counseling is a very important part. I'm seeing a few questions. So after next talk, we have a rapid fire round where we are going to show a few cases and ask these panelists that what you will actually do and what you will actually prescribe. So next talk is by Dr. Jayesh Wajirani. So those of you have asked what are the treatment for the severe cases. So Jayesh is going to talk in detail about this. So Jayesh, over to you and you can share your screen. Dr. Sangwan, in the meantime, do you want to say just a few comments on the counseling part? What do you tell your patients?
I think Himanshu has covered very nicely, and he's used very practical and layman language. So I use more common terms like patient will say, "Sir, ये कब ठीक होगा?" Just tell that, okay, this is like ये आँख का गुस्सा है. जिस आदमी में गुस्सा आता है वो कैसे ठीक होता है? आप उसको शांत रखना है. With time it will be okay. Around puberty, most of the kids get out of it. So that is, till then we need to support.
Jayesh, you can share your slides if you want.
Yes. Is my first slide visible?
No, your slide is not visible.
Okay.
We are seeing you.
Yes, now it is visible. Please, you can.
Yes. Is it visible now, full screen? Yeah.
Very much. Please go ahead.
Right. So thank you, Dr. Vikas and AIOS for this invite to speak. I'll try to wrap up quickly. I'm standing between the audience and their Saturday evening dinner. So everything that can be said about allergy has probably been covered by the eminent experts. What I'm trying to do is sum up everything into a very small and very easy to remember guideline. So keep an eye on the traffic lights because they are important. So these are my financial disclosures, but they have no bearing on what I'm going to say in the next few minutes. Right. So we have discussed that VKC needs to be graded by both severity and periodicity. So you can have mild, moderate, severe, and blinding disease. And the milder disease tends to be intermittent, whereas moderate disease can be intermittent or chronic. Severe and blinding disease usually is by definition chronic. So these are pointers because if you look at whether the disease is how severe it is and how often it happens, one can decide whether you want to manage it, being a comprehensive ophthalmologist, manage it yourself, or you want to take the help of an ocular surface specialist or if not available, maybe a cornea specialist. So like with any disease, a majority of cases fall in the milder spectrum of disease. So a comprehensive ophthalmologist would be able to manage almost 80-90% of cases on their own, but it is identifying the last 10-20% of cases accurately and referring them promptly that makes a difference in their lives. Right. So I call this the inverted traffic light guide. So you have the usual traffic lights with red on top, but here we have the green on top. So I have put these on my slides. So wherever you see green, I would recommend that a comprehensive ophthalmologist should manage it themselves. Wherever you see yellow, uh, I believe you should at least seek the opinion of an ocular surface specialist, and then maybe they can initiate the therapy or make a management plan, and then it can be followed up by a comprehensive ophthalmologist. Wherever you see red, I strongly recommend that that case should be handled by a super specialist well versed in handling ocular allergy. Right. So mild disease, the spectrum of disease has been covered. So you have very mild symptoms and very mild signs, and usually it is intermittent and seasonal. So this can be managed easily by a comprehensive ophthalmologist. How to manage has already been discussed, so I won't go into that. So this is quite clearly green, and mild disease would constitute a majority of the cases of ocular allergy, although the ones that present to us are usually more severe. When you have moderate disease, we have discussed that all the signs, symptoms are more prominent. Maybe a sign of chronicity is pigmentation in and around the limbus, on the bulbar surface, and the fornices. What I want to highlight is that when you get to the moderate spectrum of disease, there are a few things which you don't want to miss. So these patients are at a risk for keratoconus. They have been on steroids usually and will be on steroids. So you need to look at the intraocular pressure, look at the lens for any cataract, dilate and look at the optic disc at least once in a few months' time. So all of these things should not be missed. These can be done by a comprehensive ophthalmologist. However, there are certain situations where it may need co-management by a specialist. So these are some pictures that show the moderate variety of ocular allergy. So in addition to what you would do for mild disease, as people have mentioned, topical tacrolimus is very useful. And it has already been discussed that supratarsus steroids have a role in certain cases, provided that the patient is not a steroid responder. So then we come to the meaty part of the talk, which is about severe and blinding disease. So I have clubbed them together on one slide. In severe disease, it's basically an extension of the moderate VKC, where everything is more prominent. So you have more prominent signs, more prominent symptoms. Blinding disease, by definition, would have something in addition to VKC. So as a consequence of the allergy, one might have limbal stem cell deficiency. The cataract and glaucoma may be a consequence of the treatment. And as some of the numbers show, that quite a significant percentage of patients with ocular allergy go on to develop corneal ectasia. Right. So these are the patients that we're talking about. So this kind of spectrum of disease. So whenever you see such very large papillae, a lot of discharge, signs of chronicity, very dense limbal thickening causing pannus, shield ulcers, which are beyond grade 1, as Dr. Sangwan mentioned, then these patients need something more than your usual treatment. So people have discussed that they may need short courses or pulses of oral steroids. A majority of these, or at least a significant number of these, may need systemic immunomodulatory therapy. So they may need systemic drugs in addition to steroids, and therefore these are best handled. These are cases best handled by people who are well versed in these medication, as well as also the surgical aspects. Shield ulcer has been discussed. So as Sharon was showing, that with appropriate management, with debridement, with supratarsus steroids, sometimes amniotic membrane application, you can get very good results, provided the patient is managed well holistically. So blinding disease, like the bottom two pictures show, sometimes can have conjunctivalization of the entire cornea, or one can have partial limbal stem cell deficiency. And maybe as a comprehensive ophthalmologist, one might feel these are very extreme pictures and you don't see them very often. But if you flip it, and if you try and look at these complications, like we tried to look at how many of the cases of bilateral limbal stem cell deficiency were due to ocular allergy from a large cohort of patients presenting to a hospital. So it turned out that ocular allergy is actually the leading identifiable cause of bilateral limbal stem cell deficiency. Unlike in unilateral disease where it is usually burns. So you would have at least among about a third of patients of this cohort were due to VKC or AKC. So it's not that uncommon. So when you have blinding disease, this is in most cases a definite indication for systemic immunomodulatory therapy. Some of these patients need very specialized surgeries, like they may need allogenic limbal stem cell transplantation. Some of them, like Dr. Sangwan will discuss, maybe if he has time in one of the cases, they may need keratoprosthesis surgery, some other forms of surgery. So there is no point in sitting on these patients. The earlier they are managed by an appropriate person, the better it is for the patient. It's also better for the referring ophthalmologist because they don't have the headache of trying to figure out what to do, what not to do, and the counseling and all the attendant factors. Right. So one of the questions that was asked in the pre-meeting survey was about systemic immunomodulatory therapy and how to go about it. So I'm not really going into the details, but these are the drugs that we use. Like Dr. Sangwan was mentioning, the mainstay is calcineurin inhibitors, which is cyclosporin and tacrolimus. Earlier, we used cyclosporin. Now we use tacrolimus because it is equally or slightly cheaper than cyclosporin with the generic versions, and it is more effective. So the strategy is usually to start with steroids, taper off the steroids, and maintain on tacrolimus. Right? This is like, I won't go into the details, but this is some of the data that we have long-term about the use of systemic cyclosporin and tacrolimus in patients with BKC without any systemic forms of allergy, so not AKC. So in a nutshell, what it shows is that 8 out of 10 patients will do very well in the long term. So if you see the survival curve that I'm showing you right now, you'll see that it stretches up to over 5 years. So over that period, with a median follow-up of more than 2 years, you will see that a majority of patients are maintained without any relapses. So all of them achieve remission, and 80 to 85% will maintain relapse-free survival. And some of them actually you can wean off the immunosuppression after a few months or years. So the key messages are that you should categorize your ocular allergy by both severity and periodicity. And do not miss looking for things like intraocular pressure, ectasia, cataract formation, disc damage, limbal stem cell deficiency. There are a variety of treatment options available. Some of them, or a majority of them, can be used by a comprehensive ophthalmologist very safely. But there is a subset of patients which needs very specialized medical and surgical therapies. So for that, early and appropriate referral is very important. So I've just tried to summarize all of this in a slide with the green, red, and yellow, the traffic light system, the flipped or inverted traffic light guide, where as you go from top to bottom, the top are the cases where everyone should be able to manage very easily. In the middle panel are the pictures where these are the cases where maybe you would pick up the phone or send the patient once for a consult, work out a management plan, and then the patient can go towards the green or towards the red. So if the patient gets better, it's very good. If the patient is tilting towards the bottom pictures, it is time to refer those. So that in a nutshell was my message. Those of you who are interested in the super specialty, we have a very good meeting coming up in September and in Ahmedabad. And these are some of the brochures related to the meeting and the QR code for the registration. We have some very good eminent experts will be there at the meeting, and I invite those of you who are interested to attend. Thank you very much.
Thanks, Jayesh. And those of you who are watching this webinar, we have rapid fire questions on cases coming up. So whatever we have learned so far, we are going to show a case, and then one of the expert is going to tell that what will be their prescription. So finals, ultimately karna kya hai? That's what we are going to deal with. Depriya, can you share your screen? And thanks so much, Jayesh. I think this was a phenomenal presentation, and you made it very clear that what one should deal with and where you should consider. It's very important that the counseling part, the non-medical management part, and then where you should actually start the treatment. Thank you so much, Jayesh, for that. So in the best interest of time, we'll straight away start with the cases, and the panelists will be answering them. Over to you, Depriya. Depriya, you there?
Yes, sir. Is my screen visible?
Yes, visible. Please start your case.
So yeah, we are starting with this case-based, and the heading is "What's your prescription?" So basically, the first case is a 22-year-old male with complaints of itching and redness in both eyes since 1 year. He has a history of similar episodes in childhood, treated on and off with muscle stabilizers, pulse steroids. His father is a known case of VKC for the last 20 years. His visual acuity is 6/6 in both the eyes. The intraocular pressures are normal. And this is what we can see on the slit lamp examination. He has papillary changes in the upper tarsal conjunctiva left eye. There is hardly any staining. And for the right eye, the same pictures, not too much of staining. And this, we took a patient interview. So I'll play this for you.
आपके फादर को ये एलर्जी की प्रॉब्लम है, आपको कब से लगा कि ये
मैं जब 7-8 साल का था तब मेरे को थोड़ा सा ऐसा लगा कि मेरी रेडनेस थी आईज में और मेरे को खारिश हो रही थी। तो फिर हमने जैसे हिसार में रहते थे, हिसार में सिविल हॉस्पिटल में लोकली कंसल्ट किया, तो उन्होंने बोला कि जो आपके फादर को दिक्कत है वही आपको भी है। तो इसलिए फिर पापा ने मेरे को और किसी डॉक्टर के पास नहीं लेके गए, सीधा पीजीआई ले गए। तो पीजीआई में उन्होंने ट्रीटमेंट चलवाया। तो शुरुआत में तो मेरे को 2 साल तो काफी ज्यादा दिक्कत थी, मतलब मेरे को पढ़ने
Depriya, I think his volume is not there, so you can
And
shift to
Depriya
the
is
next
also
slide.
muted. She's also muted.
You need to unmute yourself, Depriya. Okay, go to the next slide.
So, basically, what is your treatment for this case? I would put this question to Dr. Swati. Dr. Swati Tomar, what is your treatment? How would you approach this case of VKC? Patient has papillary reaction and on and off symptoms.
So this looks like very much like a seasonal kind of a allergic conjunctivitis. So what I would do is that since he has a history of family history also and exacerbations in childhood, right now I would like to treat this as a chronic seasonal, or would like to take on more history whether he has off and on exacerbations or not, and would like to start especially on cold compress. If you look at my prescription, what it'll look like, it'll be like a cold compress. Then I would also add lubricants and a dual kind of a mast cell stabilizer and antihistaminic. And if there's an very acute exacerbation, that is a lot of itching, redness, and you can see the right eye has a lot of papillae also. So a short course of loteprednol would also help.
So as of now, lubricant, mast cell stabilizer, and cool compressor in this case.
Right.
Perfect.
Dr. Sangwan, any comments?
Yeah, that's right. I think he has agreed to it. So please go to next case.
Okay. So our next case is of a 13-year-old male whose complaints are itching and redness for the past 20 days. And he has recurrent episodes of ocular allergy in the past 9 years, as he says, which gets resolved with topical medications. But he has recurrence on stopping the topical medications. He is currently now on eye drop olopatadine 0.2% twice, tacrolimus at 0.1% at bedtime ointment, and lubrication 0.5% 3 to 4 times a day. And I do not have the stained pictures, I'm sorry, but these are what his pictures look like on the slit lamp. So right eye, there's papillary reaction, very active papillae, and there is a limbal papillae in both the eyes. His visual acuity in the right eye is 612 and the left eye is 6.9. So what is your treatment?
Whom are you asking this?
Yeah. Dr. Himanshu, could you please...
Okay.
Dr. Himanshu?
Yeah, so yeah, again, young child, you're talking about somebody who's recurrent allergy for a very long time. From the sign, what you can see is the UTC does seem to have scarring, which subconjunctival scarring typically. Recurrence is not responding to most of the treatment. Vision going down. I would want to make sure that I look at the topography, trying to rule out a possibility of keratoconus here. Patient is on steroid for a long time. I would also want to look at possibility of any steroid-induced cataract or any glaucoma or something. So vision not being 100% is not acceptable to me. When you have frequent allergy, which is coming too often, it's extremely important for me to refer this thing to an allergy specialist to find out the root cause of this thing. Certainly limbal form and with the extensive UTC involvement, I do prefer, like how Dr. Sangwan was saying, I do prefer to give a jab with a punch with a potent steroid. So I prefer, whenever there is a limbal form, I prefer prednisolone acetate. Again, please remember, there is nothing right and wrong in science. There are different ways of doing things. In my practice, this is how I prefer. Now, if patient is a steroid responder, of course, you would not be doing that. But if patient is not steroid responder, I would give a short course of prednisolone, which reduces the acute symptoms. which can be, depending upon how severe it is, it can be 3 days tapering or it can be a weekly tapering also, which will be followed by loteprednol and followed by lotepred-LS. Along with that, and olopatadine would be there, which will be continued for a long time. And along with that, in such kind of cases, either tacrolimus or cyclosporin would be there. Remember, cyclosporin 0.05% twice a day is for mild inflammation like dry eye and not for allergic eye disease. You want to give little more frequent as well as little more stronger. So 0.1% commercial level, if you are going for 3 to 4 times a day is certainly required there. Along with that, lubricant would be enough. But in this case, I would want to check for the topography and rule out any possibility of keratoconus. Advise to avoid direct and indirect eye rubbing.
Great. So I think this is a moderate to severe kind of case. Steroids, Predford followed by lotepred, followed by lotepred-LS, maybe for a month. Then you said olopatadine, tacrolimus, and lubricants. And
Along
investigate
with
in
that,
this
so
patient.
please remember that it cannot be followed by steroid. Olopatadine has to be started along with it because it's a mast cell stabilizer. Along with that, it has to be started as treatment, and so is your cyclosporin or tacrolimus.
So Himanshu, your prescription will have 4 drugs: steroids, olopatadine, tacrolimus, and lubricant right on day 1. And then later on, you'll taper off the steroids, will continue the tacrolimus, olopatadine, and lubricant. Correct? Thank you so much. And in right eye, it had the ISP case that was a cause. And of course, you'll rule out steroid response, you'll rule out cataract, you'll rule out keratoconus in this particular patient. Fantastic. Thank you so much. Depriya?
Should we move ahead, sir? Next case?
Yes, please. Yes, please. Dr. Sangwan, do you have any extra comment on first and second case?
I think that's what Himanshu said is would be absolutely fine. I may consider if he's like, I don't know, I'd missed the age. If he's
13 years, sir. 13 years.
13.
13.
13.
13 साल का है.
So, I mean, if he has received previous pulse topical steroids, I may consider oral steroids, a short course, and then bring him on very low maintenance dose of oral steroids and use minimal topical steroids. But that's I think it's individual choice.
We can go to the next case, Depriya.
So this is a 19-year-old male with a he's presenting with left eye itching with redness. He has a past history of itching, rubbing eyes for the last 8 to 9 years. And now very occasionally until the present episode has been on treatment in the past with olopatadine, cyclosporin, and pulse topical steroids. He's a known case of keratoconus with a history of left eye CXL being done in 2019 April and right eye optical PK in December 2017. Currently, right eye, because of the optical PK, he's on loteprednol once per day. Both eyes, he's on lubricant 4 to 6 times a day and cyclosporin 0.05%. So these are his pictures. The right eye, it's a clear graph, some minimal congestion, but the eye looks fine. Left eye, however, has these HT dots and there is congestion, there's limbal thickening. And this is the eye that has the allergic reaction. So the patient is already on cyclosporin and lubrication. So what is your treatment? And this question is for Dr. Amit Gupta.
Yeah, this is clearly a tough situation, and the presence of Horner Trantas dots, according to me, is one of the indications that I would like to initiate oral treatment, and that would be maybe for a short course of steroids. But we can look at azathioprine because he has a graft in the other eye, and to avoid episodes of graft rejection. And these patients, we can also consider giving oral tacrolimus in these patients. And if it suits him, he might do very well. And of course, the topical loteprednol long time as a preventive for graft rejection in a patient in an eye which is already inflamed. I'm not sure if he's not a steroid responder. Maybe we can consider fluoromethalone, which has slightly more penetration into the eye, and or maybe some kind of just one drop of betamethasone or some other steroid to order. We don't want to have a graft rejection in this eye, and we also want to control the disease systemically in the other eye. He's already been cross-linked, So, but I doubt that he will be contact lens tolerant. And so this is what I would do. I'd probably look at initiating some oral treatment and maybe upping the potency of the steroid in this eye. Tacrolimus topical is, I would go for that, topical
Great.
tacrolimus.
So as we can see that this case is coming between yellow to red of what Dr. Jayesh has sorted out, and the moment you are going from green to red, so you know the steroids is increased, topical is increased, systemic is increased, so that thing is has to be covered. So thanks so much, Dr. Amit, for that. Depriya, do we have any other case?
Yes, sir, we do. So this is a 9-year-old male with both eyes itching and redness and watering since 1 year. Now complains of dimness of vision and pain in the left eye. And he has recurrent episodes of ocular allergy in the past 2.5 to 3 years, which gets resolved on medications. Medications are mainly the dual-acting agents, sometimes pulse steroids. Current treatment is he's on lubrication too early, and in the left eye, an antibiotic has been added in view of the ulcer as given in his prescription. So the right eye, there is a papillary reaction in the upper tarsal conjunctiva. Within the left eye, we can see those giant papillae are there. And here we can see this oval ulcer, basically in the upper 1/3 of the cornea. And this is the stained picture. His vision in the right eye is 6/6, left eye is 6/12 parts. The IOP is normal. And what is your treatment? So this question is Dr. Radhika. Would you please like to take this question?
Hi, Dr. Devapriya. I think this is the kind of textbook description of a shield ulcer. There are some basic principles that need to be remembered while managing shield ulcer. First is we remember the allergy is very active when there is a shield ulcer. Second, we need to rule out infection. So you look at the base of the ulcer, that there is only the plaque and there is no infection. In this context, I would like to say that some of them may throw a little hypopyon also. But that does not mean that there is infection, because it may be the intense inflammatory reaction in a young child. But if the base does not carry infiltration, we are good to go. The shield ulcer is never ever going to heal unless you debride the plaque, because the plaque is just dried up mucus and epithelial cells. You're blocking sitting over there, preventing the epithelial healing happening. So you take the patient to the OT like Sharon showed, you have to debride that area very clearly, if possible, freshen the margins also. And then you take a look at the papillae. If you have multiple papillae which are causing the shield ulcer, we are better off giving supratarsal injection. Technique and amount are very, very important. I won't go into the detail for want of time. But if you have a background of severe papillae with 3 or 4 papillae which are very big and jutting out, then you may as well couple this procedure with cryo to those papillae. So combination of supratarsal steroid and cryo to the prominent papillae. This will have almost immediate relief of symptoms, and within 1 or 2 weeks, relief of the signs also. But it's extremely important to remember that these are just temporizing measures. The steroid will wear out, the cryo will wear out, and the papillae will come back. So as the ulcer is healing, we must put the patient on intense anti-allergy treatment that was described all along. And if required, one more healing measure would be to use amniotic membrane while all this is happening intraoperatively.
So this is what the case looked like after treatment. We did all that Dr. Radhika had said, and nicely healed, though the giant papillae is still there.
Corneal remodeling after shield ulcer healing is beautiful. The scar fades a lot with time.
Okay, so this is the 5th case of a 37-year-old male. He complains of mild itching and dimness of vision in the right eye. The past is a known case of VKC in both eyes since childhood, for which treatment has been taken for long. He has been on and off topical steroid eye drops, many a time self-medication. Oral steroids have also been tried, and he has a history of use of anti-glaucoma medications on both eyes for IOP control. And as per his previous prescriptions, he was on maximal medical therapy for glaucoma. So right eye, he has a glaucoma filtration surgery and an ADI implantation a few years back. So this is his right eye picture. As we can see, this is the tube of the, we can see there's conjunctivalization, LSCD. The tube of the valve is there. The vision in the right eye is 3/60. The IOP is 7 millimeters. The left eye is an absolute eye. So basically, this is a case of an advanced glaucoma with VKC. And I would like to ask Dr. Revati, how do we approach such a case, and what is your treatment?
Yeah, this is typically, as you said, VKC sequelae and LSCD. But I would like, in this case, obviously, the compromised ocular surface is one of the reasons for poor vision. In addition, we have to assess how much the glaucoma damaged the optic nerve and how much the visual problem is due to the glaucoma part also. And having said that, then we have to plan for a reconstructive procedure here, like stem cell transplants, and probably an allo slat or living donor slat, because I don't think the other eye also would have been affected.
Similar
Probably.
picture, yes. Similar
Yeah.
picture, and it's an absolute eye.
No, absolute eye, okay, but what about the stem cell?
Yes, ma'am. LSCD in the other eye also. Same,
Yeah,
similar picture.
yes. And but I could see some pigmentation all around. I'm not sure, maybe Dr. Sangwan or Vikas can comment on this. Would you like to try
So
simply?
what we did in this case is we didn't do anything. We
Okay.
used contact lenses, square contact lenses once everything was settled, and he was able to manage his work, go to school, do all those things. So we refrained from doing anything.
Yeah.
And because only one eye, so I think it will be better to, stay away. Dr. Sangwan, if you want to say anything.
No,
on that.
I would have done exactly the same because almost 2/3 or half of the pupil is okay. And with some topical steroids, lubricant, the scleral lens can work for some time. So I will consider allo slat only if the pupil is covered.
One more thing here would be a little careful about, because conjunctiva is already taken up by
OD
the
and
plants. So you don't want to disturb too much of conjunctiva, especially in these glaucoma cases. Leave it for them. Significant role of systemic immunosuppression and systemic steroid here, and along with the scleral lenses would do wonders.
Dr. Sangwan, just one question, because I could see a lot of pigmentation here. Do you think just simple AMG alone will help in recovering the stem cells, whatever are there under stress?
Yes, that Revati can be tried initially, especially if your patient cannot afford immunosuppression, or if you are scared of side effect. It may last for some time, but the peripheral recurrence will occur eventually.
I would have a little difference there, Dr. Sangwan.
So Himanshu, can I just interrupt? See, we understand that majority of the audience right now is a general ophthalmologist, and this is mainly
Highly
that there can
specialized.
be very highly specialized, and there can be difference of opinion. So I think this is taken up case by case. Depriya, if you have any other question, any other case, then we can
This is the last one, yeah. So this is a 26-year-old male, and with the chief complaints of redness, watering, itching, and gradual dimness of vision in both the eyes. Dimness of vision more for the past 1.5 years, and he has the complaints since the last 10 years. His visual acuity in both the eyes is 6/18, and this is his current treatment. He's on olopatadine 0.1% 2 times a day, cyclosporin 0.05% 3 times, and lubrication 8 to 10 times. And this is what his eyes look like. And he had papillary reaction in the upper lid. He was very photophobic. He was not allowing us to do anything. And this is a kind of inflammation he has. He already has a lot of, he already has limbal stem cell deficiency in quite a number of areas. So basically, how do we approach this? This case is, Dr. Jayesh, could you please take this up?
Does he have any disc changes?
No, he doesn't have disc changes. No.
So at the first visit, I would start this patient on frequent Tedfort eye drops and tacrolimus ointment. Meanwhile, get some lab investigations to do just to see the renal liver function, complete blood counts, and have a very low threshold for starting oral therapy, because this patient is 26 years old, has probably been on topical therapy on and off for 10 years. So explain to him, that why oral medication is required. But before starting that, I always want to check that the patient is going to come to me for follow-up, because I don't want to give the patient oral steroids and tacrolimus, and then the patient comes back after 6 months. So I start topical treatment, call them back after a couple of weeks, and then initiate the oral steroid, oral tacrolimus, and then take it from there.
Great. So last 2 or 3 cases we have seen that goes where you need to consult with some cornea surgeon specialist or ocular surface specialist, and the first mild, moderate, that can be easily managed. Depriya, can you stop sharing your screen? And we have a couple of questions that we can go through before we say it. close it. Dr. Sangwan, Dr. Ela wants to ask that which anti-allergic or antihistaminic is your choice? Olopatadine, bifostatin, sodium chromoglycerate. What is your choice?
If I have sodium chromoglycate, that will be the my agent of choice, and oral petadine for mild disease or moderate disease where I need to continue. So among these are the two choices.
Great. So olopatadine seems to be, quite commonly used and seems to be that decent choice. And anyone has used topical interferons for VKC? Dr. Murthy has asked this question. Anyone has used topical interferon, then does it really have a role?
I don't think there is any role for interferon. And I
Great. So Dr. Murthy, so nobody has used it, so that means that less likely. Dr. Sharon, there is a question for you that why in ocular allergy there is a reduced pachymetry? So can you quickly just make a quick comment on that? Why
Yes.
actually this happens? Ask is somebody rubs, why that cornea becomes
thinner. So the actual pathophysiology is that there are two things that are happening. One is the mechanical trauma to the cornea, which causes some amount of collagen change. But more importantly, because of that mechanical rubbing, that friction which is there on the surface is causing release of certain inflammatory mediators like matrix metalloproteinases, other inflammatory things, which then add on to the collagenolisis that happens in these corneas. And that again results in the thinning. So it's a two-pronged.
Okay, so Dr. Ravijit, she's want to say that exact pathology is not clear, but looks like that some kind of inflammation causes this, and it is not in all the patients, in some subset of patients this happens. Dr. Amit Patel wants to know that, Dr. Himanshu, he's asking you that, do you have any different regime for kids versus adults as far as allergies, that is seasonal allergy that is persistent throughout the year?
Yeah, so yes and no. If it is seasonal, then I may not have two different regime. But if it's persistent, if it's an adult onset, my threshold for treating it more towards AKC side would be a little more. Remember, many times there may not be differentiation between AKC because that's something which we have created, right? It's a disease spectrum where you can have VKC where it's mediated by T cells, where you can have a familial component there. So when you feel that there is subconjunctival scarring, when there is family history, multi-system involvement, I would be very keen to treat it more with long-term steroid, systemic treatment, looking at the other causes of allergy in the body. So if it is regular seasonal, no, not much.
Great. Thanks so much. It's more or less same. Depriya, do we have any other question that is left and has not been answered yet?
Sir, any family history in is it important? Like how is it related? Any like VKC patient, siblings, anything? That is one question that has recurred in the general opthal group also.
I think same thing.
Okay, so
is that when you have family history, your chances of it being towards VKC to AKC towards that side T cell mediated can be a little higher. So there, the chances of recurrence and those things would be much higher, and they may follow the similar trend what the previous generation or previous person has.
And any
Dr.
role of
Sangwan, there's a
BCL
question
in
for you.
shield? Sorry.
Yes,
sorry.
please go ahead. Please go ahead, Depriya,
No,
please go ahead.
any role of BCL in shield also, Dr. Sharon? That's a question in the chat.
Yeah, definitely. If after the debridement, you would temporize it with the BCL, or you've done an AMG, that's different. But otherwise, very often, which are not too severe, we would put a BCL, and it does help. And initially, you're treating the giant papillae, but it'll take some time for them to subside or become less prominent. So at least in the meantime, the mechanical aberration is also, protected. The cornea is protected from it. So definitely BCL.
Yeah. We have discussed also. Dr. Sangwan, somebody is asking that which allergy test do you want your patients to undergo, and is it really helpful?
I have not done. I don't normally do allergy testing, and I really don't have much opinion whether it's helpful or not because I don't have direct experience.
Okay, great.
I
Himanshu looks
do
like you want to say that. Yes, please.
I do use allergy testing a lot. To get a good allergy specialist is extremely important. Many of them have very limited panels. Many of them do not actually have experience with this thing. So to get somebody who is good into that, it's very important. Immune therapy works, but please remember, immune therapy is for many years. Remember, it's not about few days and month or something. You have to be patient enough for it to continue for at least 4 or 5 years or more. So it's not going to work if they are just going and meeting them and running away, but it does help you.
Great. Dr. Amit, there's a question for you that which is the oral anti-allergic medicine which you prefer amongst many that are available and which you feel is the most helpful? Oral anti-allergic. You were mentioning something on that.
Yeah, I was mentioning that because my son is a patient of urticaria, and he's sometimes, had a very bad attack. And how they treated him was giving him oral steroids in divided doses 2 times a day. And I think this is something which we might try in some of our patients when we give oral steroids. I am trying it in a few patients. It's giving wonderful results. The second thing which he was given was he was not responding well to cetirizine and all this, and they started him on belastin. And they did give this whole regimen, although he was better for a good 5, 6 weeks actually in tapering doses. And he did very well with that. So I did try belastin in these patients. In younger kids, you can give 20 milligrams. In people who are more than 25 kgs or so, we can give 40 milligrams and then bring it down to 20 milligrams once they respond. I'm not sure how long that period is. It does cause a little bit of sedation, but it is effective anti-allergic is usually sedates a bit. And this has to be explained. If the child has exams and all, we can't just push that anti-allergic and child is sleeping all day. But it is tolerated remarkably well in the patients, and we are now studying patients with the oral belastin. And I think maybe we can all try. So I don't
Great.
have a recommendation on that, but even oral cetirizine, it works well. Or Allegra and all these medicines, they do well. Children can be given syrups, and but for at least a duration of 2, 3 weeks, so that the allergy episode settles out. I have discussed with the pediatrician. They are perfectly okay with giving cetirizine syrup for 3, 4, 5 weeks. And although it can have some kind of side effects, but usually it's very rare. So that's
Thank you. Thanks so much, Dr. Amit. Dr.
Because
Sangwan.
just,
Yes,
just
Dr.
one or two
Please.
questions. And how about the systemic ketotifen or Montelukast? Some of my patients along with asthma, they are already using them, and some of them say that once they started that, this ocular allergy part also has come down a little bit, but still you have to treat them topically also. And another thing, cases like the last one, very severe cases, would you like to do HIV test in these patients? Because young patient with very severe, and I feel before going for a systemic medication and all, it's better to rule out that possibility also. So sometimes we have seen cases like that.
True. And Dr. Natarajan had shown that the case that sometimes it is a mimic, it mimics, and you can have a versus and also. Yes, absolutely right. You need to rule out that what is there in the systemic is there is something else that's going on. Dr. Sangwan, final comments.
Final comments. I think the presentations and everything is wonderful. Very good learning points and very digital knowledge that all of you have shared. Finally, I would like to say that all of you who are taking care of VKC or allergic eye diseases, have patience and don't scare parents, and just understand their lifestyle and their issues, and just be supportive with minimal medication, with least side effect potential and most effectiveness. And this comes with little experience and trial and error. The whatever you may read in the textbooks and journals may not be applicable to us, because most of the literature applies to Western countries and hardly not that much literature from our country. I think it's time that we should contribute our own literature and develop that knowledge base.
Great. With this, we come to the end of this webinar. Thank you so much, Dr. Sangwan, Dr. Amit, Dr. Radhika, Depriya, Jayesh, Shava, Dr. Revati, Himanshu, Sharon, Swati, everybody for staying up, for giving your precious 2.5 hours, sharing your knowledge so religiously and so effortlessly. We are really grateful to you. And thanks so much, Dr. Mathur. Do you want to make any comment on that? Any last closing remarks?
Yeah, a note of gratitude from the headquarters of AIOS. My congenial thanks to the chairpersons of the day, Dr. Samar Basak and Dr. Virendra Sangwan, the expert panel, Dr. Amit Gupta, Dr. Amit Gupta, Dr. Swati Tomar, and Dr. Revati Rajaraman, and the speakers of the day, Dr. Radhika Natarajan, Dr. Abhago, Dr. Salil Goel, Dr. Sharon DeCruz, Dr. Himanshu, and Dr. Jayesh Vajrani, and Dr. Devapriya Chatterjee for moderating the cases, and to you, Dr. Vikas, for painstaking efforts over the last 6 months, as you have said, coordinating with all the cases, the clinical material, the speakers, and then putting up this great show. It was a comprehensive refresher for all general ophthalmologists, I'm sure. So thank you all and goodbye.
Thank you so much, everyone, once again. Thank you so much. Please